Hello, 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 hello,
Hello, hello, hello, hello. Hello, hello. طب بص كده خليك هنا كده انا هعدي. hello, hello. طب بص. hello. الو 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 مايك تيست. الو الو. 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 عايز يعرف عن مشكلة.
Hello, test. Hello, hello. بسم الله الرحمن الرحيم. Hello, test. Hello, hello, hello. Test mic. Hello, 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 hello. Test. Hello. بسم الله الرحمن الرحيم. Hello, test. Hello, 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 hello. Test. Hello. إيه؟
احنا لسه ما طلعناش ده هنا.
Take the map. مش على شغل عادي. بريزنتر مش
محاضرة أحسن محاضرة كده هنيجي مش لازم كده لما درجة العالم ليه الأدب كده بس لما بقى بايخة أوي لا كترت أخطاء بصراحة بقت تقولي حاجة مالهاش أي علاقة اهلا اهلا ازيك يا باشمهندس تامر ازي حضرتك عامل ايه؟ اهلا اهلا ازي حضرتك
بسم الله الرحمن الرحيم. السلام الوطني. بسم الله الرحمن الرحيم. اللهم انفعنا بما علمتنا وعلمنا ما ينفعنا وزدنا علما. My dear professors, my distinguished guests, my dear colleagues, it's my pleasure and honor to welcome all of you in the 6th Baheya Breast Cancer Conference. أساتذتي الأفاضل، العلماء الأجلاء، لا أجد كلمات في بداية افتتاح هذا المؤتمر إلا وصية سيدنا عمر بن الخطاب لحضراتكم: تعلموا العلم وعلموه للناس، وتعلموا له الوقار والسكينة، وتواضعوا لمن يعلمكم العلم، وتواضعوا لمن تعلموه العلم، ولا تكونوا جبابرة العلماء فلا يقوم علمكم بجهلكم. It's my pleasure to introduce my professor, the professor of medical oncology in the National Cancer Institute and the ex-head of the department of the medical oncology in the National Cancer Institute, Cairo University, Dr. Baheya Zawahri, for the opening speech. Dr. Baheya.
بسم الله الرحمن الرحيم. صباح الخير جميعا، السادة الأساتذة، السادة الحضور، جميع العاملين بمستشفى بهية ومن يهتم بعلم علاج الأورام وعلاج الثدي في مصر. أهلا بكم اليوم في الافتتاح السادس، في افتتاح المؤتمر السادس لمؤتمر بهية. إنه لا يسعدني ويشرفني أن أكون دائما ضمن هذه النخبة من الأطباء القائمون على كل حاجة خير في مصر. أنا مش بشتغل في بهية بس، أنا داعمة لفكرة بهية من سنين طويلة، ومرت الأيام والنهاردة أنا سعيدة جدا إن بنحتفل بالمؤتمر السادس، ونغمض عينينا ونفتح عينينا نبص نلاقي نفسنا بنحتفل بالمؤتمر ال20 إن شاء الله وال25 وللأبد. كل فكرة خير تساعد مريض أورام في مصر أنا معاها. أنا سعيدة جدا جدا وبحييكم على استمراركم في هذا العمل الخيري الدؤوب. وأنا بنفسي ويوميا وفي عيادتي الخاصة وفي معهد الأورام القومي اللي الحمد لله لسه بروحه باستمرار، بشوف العيانين اللي بيتعالجوا بهية وبفرح من قلبي، وبعلق إن الحمد لله إن في مصر بقت عدة نواد وعدة أماكن تخدم المريضة الفقيرة البسيطة التي لا تستطيع الحصول على العلاج لو لم يكن هناك مثل بهية. أشكركم لأنكم دائما يعني تعتبروني من ضمن عائلة بهية. أنا فعلا بحس إن أنا يعني زي والدتكم، وأشكركم لافتتاح فرع في الشيخ زايد، وأنا متأكدة إنه هيكون أكثر نجاحا وتقدما مع استمرار طبعا الفرع الأساسي اللي كلنا محتاجينه. ألف شكر على حضوركم، وإن شاء الله مؤتمر ناجح وكل سنة وأنتم طيبين.
شكرا لحضرتك يا دكتورة هبة، ودايما معانا في أول مؤتمر ودايما دائما هي في كل المحافل. يشرفني إنه نبدأ بالبورد اوف دايركتورز دكتور المهندس تامر شوقي، دايركتور اوف chairman of the board director of Baheya Foundation.
بسم الله الرحمن الرحيم. شرفتونا ونورتونا. بشكركم على الحضور المؤتمر السادس. بشكركم على الحضور، بشكركم على العلم، وبشكركم على التفاعل. انا الحقيقه بحضر يعني مؤتمرات كثيره في مجال بعيد عن الطب، ما بلاقيش حجم الحضور ده، ما بلاقيش حجم التفاعل ده، ما بلاقيش حجم الناس فعلا اللي جايه عايزه تفيد ناس كثيره، وناس جايه تتعلم وناس جايه تتعلم. يعني حاجه الصراحه مبهره جدا، بالذات لما يكون الموضوع مش مرتبط بصناعه ولا مرتبط ببترول ولا مرتبط بكونستراكشن، مرتبط بحياه شخص. فكل حاجه بتتعمل، كل مجهود بيتعمل، كل فكره بتتقال، يا رب يبقى علم ينتفع بيه، يا رب يبقى فيه احياء نفس وراه، يا رب يبقى فيه جيل بيتعلم ويحل حاجات كتيره ونشيل قلم على سيدات كتيره قوي، كل السيدات مش سيدات مصر بس. باذن الله يبقى متطور واضح جدا. كل التوفيق.
شكرا يا باشمهندس تامر. مهندسه شيرين هلال، عضو مجلس اداره بهية.
صباح الخير على الجميع. أهلا بحضراتكم. شرفتونا. أنا بس كنت عايزة أقول كلمة، إن بهية طول عمرها حلم لكل ست مصرية، وحلم لكل دكتور ودكتورة. والحلم ده عمره ما هيتحقق غير بالعلم، والعلم ده من حضراتكم، من المؤتمر اللي إحنا بنواظب عليه وبنتأكد 100% إن هو بيفيد كل ست وبيفيد كل دكتور وكل إنسان عايز يعمل خير. شرفتونا، ويا رب دايما دايما من نجاح لنجاح. وأجان الحلم عمره ما هيتحقق غير بالعلم، والعلم هيجي من حضراتكم. شكرا جدا.
شكرا لحضرتك يا باشمهندسه. الان مع كلمه الدكتور محمد عماره، مدير المستشفيات والمشروعات في مؤسسه بهية وحكايه بهية.
السلام عليكم ورحمه الله وبركاته. مشرفين بحضراتكم الاساتذه الافاضل، الاطباء الافاضل، شبابنا من الاطباء من بهية ومن خارج بهية. يمكن اللقاء السنوي ده بنستناه من 6 سنين، فعايز اقول دايما بنقول ان مصر فيها حاجه حلوه. حلمنا في مصر يكبر. عمر مصر ما هتنجح غير باراده كل واحد فينا. اللي حصل في بهية عبر 8 سنين ان شاء الله هيكمل 800 سنه بعد كده، هو حلم من احلام مصر ان مصر تبقى في احسن وضع تستحق انها تكون موجوده فيه. حقيقي احنا بنفخر ان عندنا افضل اطباء موجودين في العالم. بنفخر ان عندنا افضل فريق معاون للاطباء في العالم. اللي حصل من بهية في 8 سنين هو تجمع كوكبه من الاطباء. خبره اطباء مصر من زماننا في معهد الاهرام، في القصر العيني، في الشمس، في الازهر، في المنصوره، في اسكندريه، مش لازم ننزل المحافظات، حتى اصبحنا مناره لجيلنا الاطباء من الدول العربيه. في الاخر اصبحت بؤره مضيئه للعلم تبقى موجوده. نجمع الكوكبه، ودايما النجاح بيبقى بنجاح فريق متكامل. عمر ما كان النجاح نجاح شخص. فلذلك وجود النهارده المؤتمر، وجود حضراتكم، وانا متاكد ان في جزء من حضراتكم جاي من 200 كيلو، من 300 كيلو، في ناس جايه من اكثر من كده، وجايين النهارده مسايبين اشغالهم، مسايبين عيادات، جايين من اجل هدف واحد، احنا كلنا نتبادل خبرات، نطلع باحسن حاجه في صحه المريضه، او خليني زي ما بنسميها في البدايه المحاربه المصريه. هي تستحق مننا كتير. الام والاخت والزوجه والبنت تستحق مننا مجهود كبير قوي، وتستحق ساعات وايام وليالي. يمكن ده اللي بداته بهية، وده اللي حضراتكم جميعا ساعدتوا فيه، والنهارده احنا موجودين عشان نحتفل بكده، وهنكون موجودين باذن الله، وهتوارثوا اجيال من بعدنا. يقولوا في 2015 في جيل بدا، واحنا بنكمل اجيال تيجي بعد كده. فهي امانه في رقبتكم، وتوصلوا الاجيال بعد كده، وان شاء الله تبقى مصر بجد في رفعه وفي احسن مكان تستحقها بفضل ربنا ثم بفضل حضراتكم. فيمكن شاكر لحضراتكم، وجود حضراتكم. يمكن لاول مره احنا المؤتمر السنه دي شغالين ب5 قاعات اون ذا سيم تايم، من الساعه 9 الصبح لغايه الساعه 8 بالليل، شغالين ورك شوبس جديده لاول مره تبقى موجوده في مصر، موجوده السنه دي. شغالين النهارده بحضور زخم كبير من افاضل الاساتذه الافاضل. فحقيقي المؤتمر دسم جدا، غني جدا من محاضرات كثيره من مختلف التخصصات الطبيه المختلفه في مجال الاورام. فايوه حقيقي احنا كلنا فخورين بحضراتكم، وان شاء الله يا رب على مدار يوم بكره ان شاء الله اخر اليوم نقدر نعيد التوصيات، نقدر نطلع باستفادات كبيره، ونطلع بحاجه للاجيال اللي جايه بعد كده، ويبقى علم ينتفعوا به، تبقى حاجه تفيد الاجيال كلها بعد كده. فشاكر وجود حضراتكم، وخليني ان ذا نكست 15 minutes عايز اعرض لحضراتكم حلمنا بدا في 2015. هو كان حلم، هقول كان الحلم ايه وايه اللي حصل من الحلم. يمكن في المؤتمر الاول والثاني والثالث والرابع والخامس كنا دايما بنقول احنا النهارده في مستشفى بهية الهرم، بنقدم في مستشفى بهية الهرم عملنا، في مستشفى بهية الهرم عالجنا. النهارده لاول مره بنقول احنا في مستشفى بهية الهرم ومستشفى بهية زايد. فاحنا فور ذا فيرست تايم بقينا الحمد لله مستشفيتين، يا رب في 10 سنين في 5 مستشفيات، يا رب اكثر باذن الله ان شاء الله. ويا رب تبقى فكره موجوده، هو بهية مش مكان، هو بهية حلم، بهية فكره، بهية اراده نقدر نعملها كلنا. وزي ما حضراتكم ساعدتونا كلكم وعملنا فريق واحد ونجحنا كلنا، انا متاكد نقدر نعمل بهية في كل مكان في مصر عندنا. فالنهارده بنتكلم على بهية الهرم، واقع موجود عندنا، وعندنا بهية زايد بدانا من في مارس 2023 اصبح في واقع عندنا، فاصبح النهارده بتكلم على بهية الهرم وبهية زايد. لازم نقول ان احنا بدانا الحلم في 2015، كنا اول فارس NGO توفر مستشفى في علاج سرطان الثدي في ريجون عندنا. اتبنت وقتها على 10,000 متر مربع، ولازم نترحم على السيده بهية وهبي رحمها الله، صاحبه الفكره وصاحبه الفضل وصاحبه الثواب الكبير على مدار السنين دي كلها لغايه يوم القيامه. من وهبت بيتها وقالت لاولادها انا عايزه مركز يضاهي المراكز العالميه، حلم كان موجود من اكثر من 20 سنه، وهذا حققوا الحلم اللي احنا النهارده في 2023 واقفين، ما اصبحش حلم واحد، اصبح مستشفيتين موجودين بحلم السيده بهية رحمها الله. كان عندنا حلم موجود من زمان، وما زال الحلم ده موجود في قلب كل واحد في شغال في بهية. احنا في ذا فيرست ديستنيشن اوف وومن هيلث اند سيفتي. كنا دايما بنقول من اول ما بدانا نفسنا نكون اول مستشفى. وانا بقول الاكزامبل ده كاكزامبل صغير، نفسنا بلدنا تكون احسن بلد، نفسنا نكون اول ناس دايما. فده كان دايما الحلم، وكل ما كان الحلم طموح وعالي كل ما نقدر نوصل له بشكل كبير قوي. كان عندنا ميشن ان احنا دايما نعمل بروجرامز، نستخدم مالتي ديسيبلينري ابروتش، كنا سبيشالايز في 3 حاجات، وده كان حلم من الاول: اويرنس، ايرلي ديتكشن، وتريتمنت. التوعيه والكشف المبكر والعلاج بريست كانسر، نعمل education psychological support using the latest technology. لغايه النهارده احنا عندنا ماشيين من 2015 the latest technology في العالم. ليه؟ لما جبناها في 2015 كنا باصين في 2025 هتبقى الدنيا شكلها. فاحنا دايما بنبص وات the latest technology. والساينتفك ريسيرش، والعلم لن يتوقف، واللي بيقف في مكانه مش هيستمر. كان لازم تبقى always ساينتفك ريسيرش، كانت تعتمد على الكوميونتي بارتنرشيب، واللي هي ده اكزامبل اللي فيها موجود النهارده. تعاون كل جهات المجتمع، تعاون كل اطباء المجتمع، كل هيئات المجتمع الطبيه وغير الطبيه. والانتري جروبس، والحمد لله اصبح عندنا قسم محترم من المتطوعين من شباب مصر، بجد شباب واعد يفرح. ازاي النهارده الشباب ده هو النهارده هيبقى النواه للمستقبل بتاع مصر. وانشور فاينانشال اند اوبريشنال سستينابيلتي، ذيس اند اول واي اوف ثينكينج، كيف نستمر في المشروع. دايما هو التحدي الكبير في اي مشروع بيعمل تكمل ازاي في المشروع. بدايه المشروع سهله، لكن الفكره ازاي تستمر بنفس الكفاءه باستمرار. فكان دايما ده حلم، هو 5 values: transparent, respect, teamwork, innovation and sincerity. يمكن الخمسه دول بيستشعروهم كل الشباب اللي موجوده في بهية، وده الطابع اللي موجود عندنا في شباب بهية. زي ما قلت لحضراتكم احنا عندنا 3 بيلرز اساسيين بنقوم عليهم اويرنس. لفينا 28 محافظه بالشباب بتوعنا على مدار ال8 سنين، اكثر من 1260 اويرنس سيشن، يعني في اكثر من 1260 مكان ما بين شركه، بنك، مسجد، كنيسه، جامع، مدرسه. لفينا كل الحاجه دي على الناس عشان نوصل الاويرنس للناس. هدفها ان احنا ازاي نعلم الناس وات بريست كانسر، اهميتها اند سو. والكشف المبكر، الكشف المبكر حضراتكم كلكم عارفين معناها improved cure rate، معناها انك انت العين هتخف بسرعه، اقل في التكلفه، نقدر نقلل الادويه والاثار الجانبيه بتاعت الادويه. والعلاج احنا بنعالج كل مراحل العلاج بالكامل، سواء النهارده في بهية الهرم وستيل البيشنت او الداخل ما فتحش، لكن بنعالجهم بنفس الفريق بتاعنا بنفس الفوائد بتاعتنا لغايه ما زي الويل استابلش عندنا. 2015 2023 وقفنا في محطات كانت مهمه في حياتنا. كان اول عيان استقبلناه كان في 2015 اول فايتر، كان بدايه الكشف او كان بدايه السنتر، ما كانش كل الخدمات موجوده، بس كان لازم نبدا الخدمه عندنا. فيري شورت تايم، بعدها بشهور قليله كنا بدانا اول وحده علاج طبيعي متخصصه في البريست كانسر. بعدها بشهور قليله في جون 2016 كان عندنا ذا موست ادفانسد راديو ثيرابي يونت في ايجيبت والمينا ريجن. and we are proud till this moment. احنا تقريبا مش واحده كمان سيميلر لينا، فعشان كده ستيل لغايه النهارده رغم مرور 7 سنين ستيل وي ار ذا موست ادفانسد. بعدها في ابريل 2017 كان بقى الكشف المبكر، كانت بدات الاويرنس بتاعت الناس تزيد، فكنا starting one early detection unit, then we think about having the second early detection unit. سبتمبر 2017 كان لازم فكره، احنا النهارده بنقدم خدمه طبيه، وات اباوت ازاي النهارده ده الناس تستفيد او تعرف الخدمه دي. دايما واجب علينا، ودايما بقول هو الالتزام مننا باستمرار ان احنا نعلم اجيال، فكان لازم فكره التريننج، ازاي يبقى عندنا تريننج يونت، ازاي ما قدم في بهيه الشباب يتعلموه. دي النقطه اللي احنا في مصر محتاجينها بشكل كبير قوي. لان في اكتوبر 2017 كان بدايه اول مؤتمر، كان النهارده في 2023 المؤتمر السادس، في 2017 كان اول مؤتمر، وحقيقي لازم نذكر بالخير الكراش الزيات ربنا يكرمه، هو اول انيشيتور لمؤتمر بهيه الاول، وهيكون موجود معانا في جلسات المؤتمر النهارده. فحقيقي هو كان اول من عمل انيشيشن لاول مؤتمر، وتوز فيرست داي كونفرنس، كان اول مره نعمل مؤتمر فيرست داي. في نفس السنه بدانا برضه نكمل كورسات للبول ميكس سكاننج. في 2018 كنا خدنا قرار، وكان قرار وقتها كان قرار صارم، وكان قرار ان احنا نشغل المستشفى بيبرلس، بمعنى تلبس مومنت. احنا النهارده بنتكلم في 5 سنين ونص من فبراير 2018 there is no circulating paper في المستشفى except الميديكال كونسنت اللي هو اقرار العيان بيمضيه. كل داتا العيان على السيستم، اشعه، تحاليل، الميديكال بروجرس نوتس، النيرسينج نوتس، كل حاجه على السيستم بشكل كامل، حتى الداتا الماليه وداتا المشتريات وداتا الاتش ار، كل حاجه على السيستم بالكامل. فمفيش سيكريتنج بيبر. مش عايز اقول ان احنا كنا يعني قد نقول ان احنا من اوائل الناس، ما كناش اول حد يقبل المستشفى بالكامل بيبرلس. في مايو 2018 كان بيجي عندنا، كان اول رقم وصل، كنا وصلنا 50,000، وعملنا وقتها احتفاليه وصلنا لغايه 50,000 في نيل كان تحت الكشف المبكر. كان في مراحل 3 سنين، كانت من مارس 2013 لغايه مايو 2018. في اكتوبر فخلاص خدنا بقى خدنا اسمين وخدنا السكيدول بتاع المؤتمرات، فكان في اكتوبر 2018 كان السكند بي بي سي يونت، ولكن كان بقى بدايه نبدا نعمل ورك شوبس. بدانا باول 3 ورك شوبس موجودين في السكند كونفرنس. في وقت قصير في سبتمبر 2019 كانت احتفاليه كبيره، كنا 100,000 بيشنت اندر كشف مبكر او اندر ستريم. احنا بنتكلم في حوالي 4 سنين ونص. كنا وصلنا 100,000 سيده، 100,000 سيده، مش 100,000 سيده عندها كانسر، 100,000 سيده اطمنت على نفسها. جزء كبير جدا منهم نسبه 98 وشويه منهم روحوا مطمنين، بيجوا على الانيوال فول اب، ولكن في عندنا جزء بسيط اللي تم اكتشافه وتم علاجه وبيتعالج لغايه وقتها في لغايه دلوقتي. في 2019 كان الارقام لما زادت 100,000، فاصبح البريشر على وحدتين كشف مبكر كان صعب، فكان تحدي، فكان لازم نبدا نعمل اكسبانشن، لان المين الرساله هي الكشف المبكر. فكان ثالث وحده كشف مبكر كانت في اكتوبر 2019. نوفمبر 2019 كان المؤتمر الثالث، وكان بقى كل مؤتمر بيتطور على المؤتمر اللي بقى اللي قبليه. في المؤتمر الثالث جبنا انترناشونال سبيكرز من بره، وكان بدا 3 ورك شوبس، وصلنا الى 5 ورك شوبس. 2020 دي كانت بعد 3 سنين من بدايه التريننج سنتر، قدمنا على اكريديشن دوليه تعتمد التريننج سنتر اللي موجوده عندنا في بهيه، وتعتمد التريننج كورسز اللي موجوده عندنا. فكان بدايه الامريكان اسوشيشن كونتينوس ميديكال اديوكيشن اكريديشن، فاصبحنا اكريديتد من الامريكان اسوشيشن، واصبح الكورسز، ويمكن المؤتمر ده بقى اكريديتد نمبر اوف. اكتوبر 2020 كان وحده كشف المبكر الرابع، ودي اللي موجوده النهارده في بهيه الهرم. فكان في اكتوبر 2020 كان وحده كشف المبكر الرابعه، وهنا اكتمل الكيان الكامل ب4 وحدات كشف مبكر. ويمكن دي اللارج هوسبيتال موجوده في محافظه الجيزه اللي عندها 4 وحدات كشف مبكر ديجيتال ماموجرامز. نوفمبر 2020 كنا بنفكر بياند الان تراديشنال واي اوف دايجنوزس، فكنا انتروديوسنج اول مستشفى في مصر انتروديوس البيم ستادي او البيم مامو يونت، وكنا اول مستشفى وستيل لغايه النهارده وار 2 سنترز الموجودين في مصر providing these more diagnostic services as a minimum. جت فتره الكورونا واستمرينا في الشغل، التزمنا بعلاج عدد العيانين اللي كانوا موجودين معانا، واستمرينا بالاكتيفيتيز اللي اتكلمنا عليها ليتر اون، لكن ما وقفناش كل الساينتفك ايفنتس واستمرينا في الفيجوال ساينتفك ويبينارز. في اكتوبر 21 كان لازم نبدا الحصاد، عملناها على مدار 6 سنين، وفرنا ميديكال سيرفيس ستاندرد معين، كان لازم نفكر ان احنا نبدا سايكل الاكريديشن. فكنا اول اكريديشن خدناه في فبراير 21 خدنا الايزو 9001 14001 و45001. فدي كانت بدايه الاكريديشن او الاهتمام بالاعتماد في الجوده. في مارس 21 كنا وصلنا 150,000 محاربه في الكشف المبكر. جون 21 كنا الجي سي اي، والجي سي اي زي ما حضراتكم عارفين it is the highest accreditation of hospital providing quality medical service. في هذا التوقيت كان في 10 only hospitals في مصر هم الاكريديتد بالجي سي اي، وكنا one of the top 10 hospitals في مصر accredited بالhighest degree of quality service. اكتوبر 21 كان المؤتمر الرابع، وعملنا برضه 5 ورك شوبس، وكان في جيست سبيكرز من مصر ومن خارج مصر. في جان 22 كان في برضه كملنا دوره الاكريديشن، وكان اكريديشن في الانجاج 15189 باعترافنا بالكواليتي اوف ميديكال سيرفيس اوف ذا لاب، ويمكن الريزلتس كانت اولموست 100% في كل الاكيرسي اوف ذا ريزلتس في اللاب. كان بدايه جان 22 السنه اللي فاتت بدانا بقى فكره اللانش ارتفيشال انتليجنت، وكان بدايه تعاقد مع اول شركه يونت، وتعاقدنا مع شركات تباعا، وعندنا بروتوكول مع وزاره الاتصالات المصريه. فستيل وي ار ان ذا ايرا ان دايما بنكون وات نيو ان ذا وورلد. وبدانا فكره البايوبانك ريسيرش برضه في بدايه السنه اللي فاتت. جولاي 22 كان فكره ان احنا نعمل سبيشاليزد ستيتس تو كونسيرن ميني كونفرنس، فكنا بدانا نعمل اول سبيشالايزد فيرست ساينتفك سيمينار فيزيوثيرابي، وكان في وقتها عندنا 7 جامعات مصريه اللي بيشرفونا النهارده وموجودين معانا النهارده في المؤتمر، وحقيقي كان لهم سبورت كبير نطلع باول سيمينار في الفيزيوثيرابي في جولاي 22. اوجست 22 وصلنا 200,000 محاربه، من حوالي تقريبا سنه وصلنا 200,000 محاربه. اكتوبر 22 كان المؤتمر الخامس، وكان حلمنا الكبير بدا في مارس 23 من حوالي 6 شهور، كان بدايه فيز 1 بدايه بهيه الشخصيه. كان في جون 23 كنا بدانا وات اباوت يوزنج ذا تكنولوجي، فعملنا اول فيرست انترناشونال ام دي تي ميتنج ويبينار، وكان في عندنا كان معمول مع رويال كولج اوف باثولوجي في انجلند، وكان معمول مع اطباء عندنا من بهيه مع اطباء من انجلند، وكان ديسكاسنج الحالات وهاو تو ريتش الدايجنوز، وايه راينا وازاي احنا نثقل المواد التكنولوجي العلميه عند الاطباء. في اوجست 23 كان لازم نكمل بقى السايكل العلميه، فكان المؤتمر الثاني للعلاج الطبيعي والسبيشالايزد فيزيوثيرابي كونفرنس، وبرضه استمرت الانترناشونال ام دي تي ميتنج، كان في السكند انترناشونال ام دي تي ميتنج ودسكشن حالات اتشخصت في بهيه في الام دي تي وناقشناها بره وشفناها، وكان لينش بيتر دايجنوس. اكتوبر النهارده واحنا في المؤتمر احنا ار لانشنج ا نيو بروجكت اللي هو السكند بروجكت، هيكون في سيشن كامله هيبقى زمايلنا هيتكلموا على السكند بيريود وازاي هنوصل، كل ده هدف نوصل وات ذا بيست دايجنوسس let our colleagues in the session is a separate session for the second period. دي كانت بهيه في 8 سنين، ده اللي كان الحلم اللي انا بقوله، ده كان حلم كان مخطط. يمكن مش عايز اقول ان في حاجات اتحققت في وقتها، في حاجات بفضل ربنا اتحققت قبل ما علينا. الحلم في تبقى في حاجات خلال السنتين الجايين، نبدا بقى المرحله الثانيه زي ان شاء الله باذن الله، يمكن ده هنكمل حلمنا ان احنا يبقى عندنا ذا موست ادفانسد راديوثيرابي يونتس في الشيخ زايد زي ما عملناها في 2016 في الهرم، ففي 2024 هيبقى عندنا ان شاء الله في زايد الوحده الثانيه. ازاي يبقى عندنا كومبليت ابديتد كومبريهنسيف باثولوجي ده فيري سون ان فيو مانثس ان شاء الله باذن الله في الشيخ زايد. هنكمل رينيول كل الاكريديشنز وذ جي سي اي ار ايزو سو اون، وهنعلن يمكن برضه الدكتور ماهر حسيب بقى يعلن عن في المؤتمر عندنا. هنعلن في بدايه 24 we have a special training programs hands on training في different specialties في الميديسن. I'll give the floor to دكتور ماهر later on هيدينا ديسكشن عن الهاندز اون تريننج. يمكن دي احد المفاجآت اللي موجوده عندنا في المؤتمر. also من الحاجات الجديده اللي هي فكره الجينيتك يونتس دي هتبقى لانش برضه عندنا فيري سون ان شاء الله قبل نهايه السنه دي او مع بدايه السنه الجديده ان شاء الله. وبعدين هيبقى عندنا نيو بين سي تي سكان يونت. يبقى دي هتبقى دي عندنا بقيه احلامنا وبكده نكون قفلنا الاحلام المؤقته عشان نبدا بقى احلام اوسع واكبر باذن الله ان شاء الله. يمكن دي الاكريديشنز اللي بتاع حضراتكم خدناها عبر السنين. يمكن لو عايز اعرف بس ارقام عشان فور ديمونستريشن احنا وصلنا توتال اندر سكريننج 236,000 سيده. في الزيارات العيادات الخارجيه اكثر من 3 مليون زياره على مدار ال8 سنين. اللي عملوا اير ديتكشن يونت نص مليون عندنا باعتبار الحساب بتعمل اكثر من مره. عملنا اكثر من 100,000 كيموثيرابي سيشن، عملنا اكثر من 4 مليون راديو ثيرابي سيشن. العمليات عملنا ما يقرب من 20,000 عمليه. في المعامل عملنا 1.5 مليون تحليل على مدار الفتره دي. وفي الفيزيوثيرابي عملنا اكثر من 70,000 جلسه علاج طبيعي. يمكن برضه من المفاجآت اللي الدكتور محمود كامل عاملها في احد السيشنز برضه عندنا الكانسر ريجستري. يمكن النهارده احنا بنانونس يمكن برضه المؤتمر انا بس حد تو سلايس واسيب الدكتور محمود في السيشن اشرحها بالتفصيل. احنا لاول مره عندنا النهارده كانسر ريجستري حقيقي على داتا موجوده في بهيه. I would like to thank طبعا فريق الابحاث. I'd like to thank شباب الاطباء اللي ساعدونا في الداتا. I'd like to thank التكنولوجي اللي ساعدتنا نوصل للقصه دي عندنا. احنا واصلين عندنا في ناس عندنا الناس عندنا في ستيج 0 كانت ديسكاسنج ان احنا دايجنوز ناس في ستيج 0 2%. عندنا ستيج 1 و2 حوالي اكثر من 50%. فاحنا اولموست 53% من الناس دايجنوز بدري. عندنا ستيل برضه ذا كالتشر ار بوشنج فور ان احنا قللنا ستيج 4 ل 13% اللي هي مراحل الميتاستاتيك. وي ار بوشنج ان هنجيب ستيج 4 كلها بدري ونجيب ستيج 3 بدري. فدي ذيس ار ريال داتا عندنا في العين. عملنا برضه كانسر ريجستري في الكانسر سرفايفل 1 يير سرفايفل 97.9%. ال 3 year survival 94.2% وال 5 year survival 90.4%. By the way, this is aligned with the international standard. So I would like to proud with yourself that you achieve now is going that we achieve the international standard. شكرا جزيلا لحضراتكم على كل الانجازات اللي حصلت. انا يمكن حضراتكم اللي زاروا بهيه او يزوروا بهيه عندنا النهارده كل العيادات موجوده عندنا سواء في بهيه الشيخ زايد او بهيه الهرم بالديفرنت سبيشاليتيز. وعندنا برضه كل الدايجنوستيك والتريتمنت يونتس موجوده. وطبعا ام دي تي احنا النهارده بنعمل ام دي تي دي عندنا كل يوم ام دي تي discuss the best diagnosis approach لكل البيشنتس عندنا. حاجات من النقط اللي بهيه السايكولوجيكال سبورت شيز ا فيميل فور كانسر عندها دبل اتاك. فازاي النهارده ان انا اخرجها من النفسيه بتاعتها وافهمها ان دي كيورابل ديسيز وانها تواجه الحياه دي لازم. عندنا فريق كامل. يمكن برضه عندنا سيشن يوم الجمعه هنتكلم فيها بالتفصيل. فحقيقي اقول لك ثانك اور تيم فور ا جريت ايفورت فور سايكولوجيكال سبورت. Let's say some pictures of بهيه الهرم. يمكن حد من حضراتكم شافها. ده زي السريع البيكتشر صور حقيقيه من الموجود حاليا. This is a real picture.
هي أدرك على مدار 7 سنين لكن الشيء زي بس على مسافة 80 كيلو فمسافة بتكون 85 المسافة. نريد أن نقدم المستشفى لتشكيل الدم وعلاج سرطان الثدي بالمجان. مستشفى بهية الشيخ زايد الكتير حتى نقدر نقدم عشان نحولها لكل 6 مستشفيات. المستشفى هتكون هذا الأمر المستقبلي هو مساعدة السيدة خلال مراحل المستشفى يتم الرئيس على أساس الأجهزة الطبية هنا هيكون كل مراكز معلومة مفصولة ومتابعة عشان يوصل لأحدث الطرق الطبية ونحن نكون هنا مساعدتكم تكون سبب في الوضع الأسرع شو يصير بالسلم
ان شاء الله اكتوبر اللي جاي اكتوبر 24 باذن الله.
يعني شرف كبير ان هو يدينا كلمه بسيطه عن المنطقه.
طب احبس الوعي شويه. طب ممكن نجيب المحاضره بتاعتي وبعدين نبقى. بس انا بسم الله والحمد لله والصلاه والسلام على رسول الله. عاوز اقول وحشتوني، انا بقى لي سنتين غايب. يعني ذكريات كبيره جدا جدا، نرجع ورا من 2014 من مره اتقابلنا في جول انا وواحد اسمه تامر شوقي. تامر شوقي حماس الدنيا فيه لدرجه اني كان دايما لما تجيلي مكالمه بعد الفجر مباشره اعرف ان تامر شوقي بيتصل عشان يدي باله في البهيه. مرينا بمراحل كثيره جدا كانت كلها حماس، وانا كنت متاكد ان احنا هنوصل لكده واكبر من كده. يمكن كان في ناس ما تتخيلش من الاول، لا انا كنت على يقين ان احنا هنوصل لكده. كان في تكاتف حاجات كثيره انا كنت متاكد منها.
كان بالعقليه الجباره والدينامو اللي ما بيهداش تامر شوقي. ما ننساش ابدا الدكتور محمد جمعه دكتور القلب، كان هو مش موجود دلوقتي بس واحنا لسه بهية طوب احمر، كان لا يكل ولا يمل وعنده حماس شديد جدا مع انه تخصصه طب امراض القلب، انما له فضل كبير جدا جدا عليها. طبعا ما ننساش في بدايه بهية ان احنا اعرف ان يكون جنبنا الدكتوره اماني هلال والدكتور رشا كمال، ده يديك حماس كبير. برضه ما ننساش الفضل لله سبحانه وتعالى، ثم للدكتور احمد شرف اللي اسس لنا وحده العلاج الاشعاعي، نختلف معاه بعد كده او لا، انما هو اللي اسس وحده العلاج الاشعاعي. الدكتور احمد حسن عبد العزيز اللي اسس لنا وحده الابحاث، برضه كلنا بعد كده كل واحد بيشوف طريقه، وانا ما كانش عندي اي شك ان هي هتوصل كده. يعني ولادي واخواتي الصغيرين اصبحوا اساتذه كبار قوي، وده يشرفني ان انا في يوم من الايام كنت بقعد معاهم على نفس الكرسي. شكرا.
جزيل الشكر دكتور اشرف. والان مع كلمه الدكتوره جيلان احمد سي او بهية فاونديشن.
السلام عليكم، شرفنا ومنورينا النهارده. اعتقد الاساتذه قالوا كل حاجه، الدكاتره يعني قالوا قبل كل حاجه، مش هطول عليكم، بس عايزه اقول لكم ان احنا من اول يوم من 8 سنين واحنا مؤمنين ان احنا مش هنقدر نساعد محارباتنا ولا نقدر نعمل لهم دعم نفسي او طبي غير بالعلم، غير ان احنا لما نكون بنمارس طول السنه كل الابحاث العلميه وبنطبق كل البروتوكولات الحديثه وكمان احدث التقنيات، وده اللي بنتوجه في مؤتمر سنوي اللي موجود النهارده، الحدث الجلل بتاعنا اللي بيحضروا علماء اليوم وكمان طلبه اللي ان شاء الله هيكونوا علماء قدام. ومن خلال حضوري للخمس مؤتمرات السابقين يعني باكد لكم ان شاء الله هيكون في نقاشات جاده مثمره باذن الله، وورك شوبس كمان مفيده جدا. خلونا نحضرها مع بعض ان شاء الله، وبحضوركم اللي بيشرفنا اكيد هنفيد ونستفيد. شكرا لكم ومنورين.
شكرا دكتوره جيلان. دكتور امجد هاشم سي او بهية سنتر هرم.
السلام عليكم. مش هطول برضه طبعا. الدكاتره قالوا كل حاجه او الكلام. انا بس عايز اقول 3 حاجات بسرعه. اول حاجه بشكركم جميعا على تشريفنا، وبشكر كل القائمين على المؤتمر. مش هقول اسامي لان طبعا المشاركين في الجهد ده ناس كتير جدا، ما ينفعش ان انا اقول اسامي واسيب اسم واقول اسم. بشكر مجلس الامناء كله اللي بيحضروا وعاملين سبورت كامل لكل ما هو مفيد وساينتفك، وكل ما هو يعني كوميتمنت انا ما بشوفوش في اماكن كتير انا اشتغلت فيها قبل كده. تاني نقطة طبعا بأكد مرة واثنين وثلاثة، المؤتمر مفيد جدا. المؤتمر فيه ورك شوبس وفيه محاضرات سبيكس مختلفة، حاجات مختلفة. يعني هتلاقوا حاجات كمان موجودة. يمكن احنا طبعا البريست كانسر والجديد في البريست كانسر والحاجات اللي زي كده تلاقوها موجودة. هتلاقوا حاجات كمان زي البيشنت نافيجيشن، زي السكند بين زي ما محمد قال. حتى يعني عايزين نستفيد. انا ابقى فرحان جدا جدا لو في وقت من الاوقات دكتور من زمايلنا لما يجي يعمل حاجه يقول انا سمعتها في مؤتمر بهية، الكلام اكريديتد زي ما الدكاتره قالوا قبلي، احنا واخدين اكريديشن من الامريكان اسوشيشن، الكلام ساينتفك واكريديتد. صدقوني ممكن نطلع بحاجات هنا تفيد مريض ممكن يكون محتاجها، ممكن كلمه صغيره من الدكتور، ودايما احنا بنقول الكلام ده، بتفيد في التشخيص، بتفيد في العلاج، بتفيد ان احنا ناثر على مريض رحله طويله جدا. ثالث حاجه، احنا عندنا ايمان قوي جدا بالفريق الطبي بتاعنا. الفريق الطبي بتاعنا فريق متميز جدا، واللي شاف وعرف في اماكن ثانيه واشتغل في اماكن ثانيه وشاف الخدمه الطبيه هيعرف الفرق بهية. عندنا ايمان قوي بالفريق الطبي.
عشان كده احنا ابتدينا في بروجكتس عشان ننقل. احنا طبعا في الاول وفي الاخر احنا بيشنت سنتر، احنا مهمتنا الرئيسيه هي البيشنت، ولكن احنا شايفين ان احنا في الوقت الحالي كمان محتاجين نتوجه لزمايلنا الدكاتره والخدمه الطبيه عامه في مصر. احنا زي ما بيقول الدكتور محمد، احنا عملنا لونش السكند اوبينيون. السكند اوبينيون ده بروجكت عشان خاطر يعني نبتدي ندي السكند اوبينيون لكل القرارات الطبيه لكل زمايلنا الدكاتره. الفلو عندنا والخبره للفريق الطبي اللي عندنا، الانتيتي المتميز جدا عندنا يسمح ان احنا ندي سكند اوبينيون للناس، نأثر على المريض رحله طويله بقرار ممكن يكون مختلف او يكون في الترناتيف احسن. عندنا ايمان في الفريق الطبي ان هو ممكن يغير الخدمه الطبيه في مصر، خصوصا في الاريا بتاعه البريست كانسر. زي ما نزلنا ووعينا في اول بهيه وقلنا ان احنا هننزل عشان نوعي الناس والايرلي ديتكشن ونوعي المرضى، اعتقد ان هو جه الوقت ان احنا وهنقدم بروجكتس الفتره الجايه ان احنا نعمل ساتلايتس ونبتدي نوعي الناس، حتى مش نوعي بقى، انا اسف الكلمه مش دقيقه قوي، نحاول نمد خبراتنا اللي موجوده نتيجه التعامل والفلو الرهيب اللي عندنا اللي بهيه وكميه الخبرات المتراكمه عندنا، نمد بيها زمايلنا عشان نحاول نويفاي السيرفيس. انا املي او املنا بهيه ان احنا المريض اللي في اقصى جنوب مصر، في اقصى شمال مصر، في اقصى غرب مصر، في اقصى شرق مصر، ياخد نفس الخدمه اللي المريض اللي فيها باين. في ناس كتير ما عندهاش الفرصه ان هي تيجي بهيه. نتمنى من حضراتكم، احنا الفريق الطبي بتاعنا زي ما بنعمل مؤتمرات دلوقتي نحاول ننقل خبرات ونتشارك مع بعض في الخبرات. عندنا امل كمان ان احنا الفتره الجايه ننزل محافظات مصر كلها ونحاول ان الخدمه اللي بتقدم في بهيه ان شاء الله باذن الله تتقدم لكل سيده في مصر. شكرا حضرتك.
شكرا دكتور امجد. دكتور محمد مدحت سي او اوف بهيه سنتر زايد.
السلام عليكم ورحمة الله وبركاته. كل سنة وحضراتكم طيبين، كل مؤتمر وإحنا وحضراتكم طيبين، وبهية إن شاء الله تقدم مستمر سنة عن سنة. وفي الحقيقة أنا يعني دايما حظي بيبقى وحش إن أنا بيجي اسمي بترتيب الكلام في الآخر، وده بيصعب عليا الحقيقة بعد أساتذتي الكرام وزمايلي الفاضل. في الحقيقه ما بقاش في حاجه فعلا اقول غير ان انا ارحب بحضراتكم، ارحب بالعلم اللي انتم جايين تقدموه، بالتشالنج الحقيقي اللي احنا كلنا موجودين هنا عشان نواجهه بتقديم خدمه صحيه محترمه في الوقت اللي الظروف الاقتصاديه بتضغط على الناس وبتضغط على المصريين بشكل عام. احنا موجودين هنا في بهية عشان نخدم على سيدات مصر بخدمه طبيه فعلا محترمه. وانا عندي ايمان راسخ ان لو المنظومه بتاعت بهية دي اتطبقت في نص مستشفيات مصر، اعتقد ان المنظومه الصحيه في مصر هتتحرك بشكل. في الحقيقه الدكتور محمد بيعرض البرزنتيشن بتاعه، انا سرحت كده ثانيه وشايف اساتذتي وزمايلي والحضور الكرام كلهم. ان شاء الله في اكتوبر الجاي المؤتمر ده بيتعمل في قاعه المؤتمرات بتاعتنا في الشيخ زايد. باذن الله ان شاء الله على وعد ان احنا المؤتمر الجاي الشيخ زايد هتبقى ليها بصمه كبيره في علاج السرطانات الثدي في مصر وفي العالم. احنا ما بننامش تقريبا، عندنا حلم احنا مش شايفينه وبس، احنا حاسين ان على طرف صوابعنا كده. الصور اللي احنا شايفينها ديجيتال دلوقتي في 24 احنا خلاص على اعتاب انها تبقى حقيقيه. ايماننا الحقيقي ان بهية بتقدم خدمه فعلا تستاهل ان احنا نبذل فيها مجهود، يعني سيدات مصر يستاهلوا ده اللي مش بيخلينا فعلا ننام. في الاول وفي الاخر وجود حضراتكم هو اللي عامل بهية، هو اللي فارق في العلم، وهو اللي فارق كمان بالناتج الاخير اللي انا شايف ان احنا كبهية بدانا نغير ارقام معدلات الشفاء وبنوصل لمعدلات عالميه، وان شاء الله في يوم من الايام هيبقى الرقم بتاع بهية هو ده البنش مارك اللي الناس رايحه تعمل زيه. اهلا بحضراتكم، ان شاء الله مؤتمر مفيد نتبادل فيه خبرات كبيره ونعمل فيه دائره معارف اكبر. وانا شايف اساتذه وقامات وهمات كبيره جدا في مجال علاج سرطان الثدي وفي مجالات الطب كافه الحقيقه. شايف زمايلي فهي منورين كالعاده. اهلا بحضراتكم، كل سنه واحنا وانتم طيبين، ان شاء الله مؤتمر ممتع ومفيد.
شكرا دكتور محمد. الان مع الدكتوره ايماني هلال رئيس المؤتمر الدولي.
صباح الخير عليكم جميعا، منورينا ومشرفينا. It's my honor and pleasure to welcome you all to our second international Baheya Breast Cancer Conference. الكونفرنس اللي بدأ بحلم صغير initiated بالدكتور أشرف الزياري في يوم علمي واحد مؤتمر في مستشفى بهية، وكبر سنة ورا سنة. ما حدش يتخيل مدى السعادة اللي أنا حاسة بيها مع الدكتور دوت، والنهارده سادس سنة، ويا رب زي ما قالت الدكتورة هبة السنة 20 30 والعمر كله. الحقيقة المؤتمر احنا كل سنة بناخد خبرة وكل سنة بنحاول نخليه أحسن. بشكر الأساتذة اللي خدوا من وقتهم وشرفونا، وأكيد وجودكم بيثري جدا. المؤتمر بيعلم الصغيرين والكبار، بيتبادلوا الخبرات، وكله لصالح المريضة المصرية. فكرتين مهمين قوي الحقيقه جودي دلوقتي. احنا لما بناخد فكره وبنشتغل عليها بمنتهى الاخلاص زي مستشفى بهية لوجه الله، فريق كامل بيشتغل بطريقه تكاملي وليس تنافسي الحقيقه، بالعلم برضه، لان ما فيش حاجه بتمشي من غير تخطيط ومن غير علم. وكانت النتيجه ان الحمد لله يا رب كل سنه احسن من السنه اللي قبلها. ما فيش كمال، لكن ما فيش حاجه اسمها ما فيش احسن، دايما في احسن، وكل سنه بنشوف الاحسن ده الحمد لله. الحاجه الثانيه فكره ان احنا نبقى متخصصين في علاج مرض واحد، قد ايه الفكره بتنجح وقد ايه بيكون خادم لكل الناس. من 10 سنين فكره ان احنا نشتغل بس اورام ثدي كانت فكره غريبه، لكن دلوقتي في فريق عنده خبره كبيره جدا جدا في علاج اورام الثدي، جراحه وطب اورام واشعه، فريق متكامل. الحقيقه النتائج والخدمه اللي بنقدمها للمرضى تخلينا دايما فخورين ان احنا قدرنا نبدا كده ونكمل ان شاء الله على طول كده. اشكر جدا جدا فريق الاورجنايزنج كوميتي دكتوره رشا كمال، رغم تعبها الحقيقه ما كانتش بتسيب اي تفصيله لما تكون موجوده فيها. ماهر دينا من المؤتمر، دعاء، البنات، كل التيم بتاع بهية، ما فيش حد واحد. الحقيقه التيم كله كان نفسه الموضوع ينجح. ان شاء الله باذن الله المؤتمر السنه دي اكسباندنج جدا، وفي ورش عمل كتير ومحاضرات كتير، وان شاء الله باذن الله بوجود اساتذتنا وزمايلنا المؤتمر يكون فروتفول ونافع للناس كلها. شكرا جزيلا ونورتونا وشرفتونا، وهنبتدي ان شاء الله اول جلسه. الف شكر.
شكرا دكتوره اماني. انا بس بحب اوضح لحضراتكم احنا عندنا 3 قاعات في الفلور هنا، هول A وB وهول C. هناك هول A B و C. عندنا لوب 5 لوب 6 في يعني جاست اب ستيرز، كلهم شغالين بارل دلوقتي، وان شاء الله نفايت التشير بيرسونز اوف ذا فيرست سيشن تو ستارت ذا فيرست سيشن.
الدكاتره يتكلم هو قاعد في حد انا اللي حطيتها لو يعني، فانا بسال بس عشان لو كده هشد كله بيقول يتكلم على طول.
شغال. اتفضل. حالا حالا اتفضل. في حالا حالا اتفضل
ماهر قول لي لو عايز نبتدي في اي وقت. صباح الخير صباح الخير. لو سمحتوا يا جماعة ممكن نقعد علشان عايزين نبتدي الفيرست ستيشن لو سمحتوا. صباح الخير. حاضر. لا هما بيمشوا، اللي بيمشي يمشي. We are going to start the first session. It is my pleasure to announce the starting of the first session, a new era in breast cancer management. Our first speaker is Dr. Ashraf Zayat. He will talk about breast surgery, the past and the future. دكتور أشرف الزيات موجود؟ تمام. صباح الخير يا دكتور أشرف.
بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. أنا سعيد جدا بالحضور النهارده وهنبتدي. أنا فضلت إن احنا نعمل أول محاضرة اللي هي نتكلم فيها على تاريخ البريست كانسر. يمكن هنرجع ورا من أيام الفراعنة ليومنا هذا، وإيه البراكتسز الريكومندد ناو، وازاي التطور حصل على مدار 6000 سنه. بس بما ان احنا هنا في بهيه ما اقدرش ورا الكلام اللي كانوا بيقولوه من شويه في البرزنتيشن هنا، ان احنا كنا بنبتدي في اوضه صغيره، كانوا شباب متحمس جدا، كنت بقعد كده وماسك ورقه وقلم واحنا في اوضه العمليات اشرح لهم هنشتغل ازاي والقوانين بتمشي ازاي، وكنا في اوضه صغيره غلبانه كده في الجيزه. النهارده احنا قاعدين في قاعات كبيره، الشباب متحمس جدا، مسكوا الرايه وما شاء الله عليهم فيها. بعد شويه طبعا بالمجهود الواحد بيعجل، بقيت قاعد على كرسي وهم اللي واقفين، ليس الا احترام ليهم، لكن ركبي كانت تتعبني، فكان لازم احدي كثير قوي. من لا يشكر الناس لا يشكر الله. وفقط سهوا مني اني اقول ان في بدايه بهيه او في ولاده اي مشروع بتحتاج حاجات كثيره، اسس كثيره جدا عشان تعمل مشروع. بهيه كانت عباره عن ورقه، وانا كنت مسميها ماي فيجن بهيه سنتر. طبعا ما كانش حد عارف يعني ايه نعمل بريست كانسر، ليه ما نعملوش تورام انما هي كانت بيس اوف بيبر، بس يوريك قد ايه القلوب لما بتتكاتف. البيس اوف بيبر دي تحولت لصرح، بس مش صرح واحد، ده صرحين وان شاء الله 3 واكثر. فبدانا من اوضه صغيره ووصلنا لان احنا قاعدين مع بعض النهارده. من قواعد ان الواحد يبدا مركز كبير يحتاج ناس تعمل له ستابيليتي، فما كانش فيه اكثر من الدكتور حسام عمر، اول استاذ واول رئيس قسم الجراحه الاورام الثاني في مركز بهيه. بنشكره جدا جدا لانه كان عنده الحكمه وعنده الاحترام الناس كلها ليه، ان هو يدينا دفعه كويسه جدا كنا محتاجينه في الاول. لكن كان بعد كده هو حبينا ننتقل لمرحله جديده، فكان لينا الشرف ان احنا اطلب من اخويا الصغير ماهر حسن، زي ما قلنا هو الدينامو دلوقتي في كل حاجه بروح الشباب، ولانه عارف مصر كويس قوي كنا على يقين ان احنا نقدر ننقل نقله جديده بوجود الدكتور حسام عمر معاها. الدكتور ماهر حسن بعد الدكتور حسام عمر. بعدها قدرت انا استريح واكتشفت حاجات كثيره في الحياه، ان الواحد ممكن يستمتع باحفاده وممكن يلاقي فرصه انه ينام ويصرف الفلوس اللي بيكسبها طول اليوم زي ما انتم شايفين. بس برضه ما اقدرش انسى هنا دور المايسترو لنشأة بهيه في البدايه. احنا كتبنا قوانين وجبنا اجهزه وعملنا مالتي ديسيبلينري تيم، بس كان لازم في مايسترو يقدر يمسك الكلام ده كله، وكان ربنا سبحانه وتعالى رزقنا بهذه الشخصيه دكتوره او الاستاذه دعاء السيد ابو كريشه، اول منسقه فينا، هي اللي عرفت تربط كل حاجه ببعضها، وليومنا هذا هي دينامو حقيقي. كان ممكن كثير جدا يكونوا غايبين، بس في عمرنا ما كنا هنبقى بهيه بدون دعاء السيد ابو كريشه، انا دايما بشكرها جدا جدا جدا. نتكلم شويه عن دلوقتي. Breast cancer, as we all know, is the most diagnosed cancer worldwide. It is the major cause of death, cancer related in women worldwide. ولكن الحمد لله, as we can see, there's a lot of improvement in the management over the years. Early diagnosis definitely improves the outcome. Our understanding is really increasing, and now we became a multidisciplinary specialty. ونتكلم حته كده history من ايام الفراعنه. كان the pharaohs they described it as a bulging tumor, but they never ever had any surgical input. It was just called a bulging tumor. We all remember the Edwin Smith papyrus. It's not really related to breast cancer. انما بس بيوريك ان كان في ايام الفراعنه they were really interested in surgery. Edwin papyrus او Edwin Smith papyrus was a paper was written in 1500 BC. It was brought by a merchant called Edwin Smith from a villager in Luxor, and that was a lot talking, a lot of it about surgery in the time of the pharaohs. I'm just going through photos, just pictures. This is Imhotep, and we go to Hippocrates, 400 BC, and followed by Galen, 129 AD. They described breast cancer, but they talked about it as accumulation of black bile. They considered it as a systemic disease with external manifestation because it used to be fungating with this yellowish, blackish fluid. So they thought it is external manifestation of a systemic disease. And then the Greek, they described it as carcinous, because when they cut it, there are lots of blood vessels going into the tumor. So they described it as carcinous, which means cancer. Al-Kaburia, as the Arabs called it. Saltaun, which is al-Saratan, because they used to cut it and they see the blood vessels going into it. So it's a bit of history. And then we also, the Arabs talked about cancer, but again, not specifically about breast. Ibn Sina or Avicenna, as they described it, Abu Qasim al-Dakhrawi, but they talked a lot about surgery. Until the 18th, 19th century, when really it started to go into more details. Is it inspissated secretions, trauma, infection, personality disease, sex-related, spreading through the lymphatics, maybe? But we owe a lot to William Orsted in 1892 when he described his radical mastectomy. At that time, there was a lot of improvement in sterilization, in-block excision, anesthesia. So that gave him the chance to go for that radical mastectomy. He managed to reduce local control, local recurrence, yet still its survival was not really much improving. It became the standard until 1976 when we do radical mastectomy, and then we moved from radical mastectomy to modified radical mastectomy to Paty mastectomy to modified Paty mastectomy, all until 1957. Lots happened in 1957. Not just that I was born, but more importantly, the NSABPP, our National Surgical Adjuvant Breast and Bowel Project, was established and conceived in 1957 in America. And thanks to Bernard Fisher, there were hundreds of trials until today that changed the face of management of breast cancer. And Verinosi as well, the late Verinosi. And then in 1976, we described that unless you go for adjuvant therapy, there will be no improvement in survival. So it became the equivalent conservation plus medical treatment and radiotherapy equals improved survival. So we started the conservation era from 1976. So surgery, in short, from no intervention to radical mastectomy, to modified radical mastectomy, Paty mastectomy, modified Paty, breast conservation, and then the axilla, from axillary clearance to level 1, 2, 3, level 1, 2. Now let's go for axillary sampling. Let's go down to sentinel node in 1992. And then we started again sentinel node to clearance or sentinel node and radiation, the analysis study, or no nodal surgery at all, as we again heading into this era now. This is a sentinel node, as you can see, the technician and the blue dye. I just have to mention here, please, there is something new. All surgeons have to be aware of it. The metaplastic carcinoma is already more and more being diagnosed lately. It constitutes about 1% of the tumors, sometimes difficult to differentiate it from the phylloides tumor. It is always triple negative. It's about 1% of all diseases. Please, regardless of the size of the tumor, no new adjuvant therapy here. You have to go for surgery. They never, ever respond to new adjuvant therapy. And actually, even without that, after surgery, you might not even need radiotherapy or chemotherapy. Phylloides tumor, again, it was reported by Johannes Müller in 1838 and was described as cystosarcoma phylloides. But World Health Organization in 2003 described it as phylloides tumor. It's benign, borderline malignant, and we really have to be aware of its management. It's a bit of history. Again, reconstruction, Veneur, in the French surgeon in 1887, he moved tissue from normal breast to another breast. Thirdly, he moved lipoma into a breast to reconstruct it. The company of Cronin, Thomas Cronin, in 1961, he established the first silicone company. Latisma Dosai will describe over the years. The latest one was Boswick, and we had a very nice book also describing the operation. Tram also in 1979, the three flaps. Other surgical specialties came into on the table to improve survival. We now have oligometastasis, we have liver surgeons, we have brain surgeons, we have lung surgeons. Plastic surgery came in. Nodal surgery has changed significantly. We need a thorough assessment of the axilla currently. Central node has to be the standard. Affected nodes marking will be good practice when feasible. Your techniques, blue dye and technician will be appreciated. And level 3 dissection should be discouraged, absolutely obsolete. Lymph node transfer is being practiced nowadays to prevent delayed lymphedema or to treat delayed lymphedema. We have Ashraf Abdul Fatouh and many others here in the country who can do that. Lymph node free grafting from the groin into the axilla, lymphovenous anastomosis, lymphovenous shunts. It's really now becoming more and more practiced worldwide, and it is now practiced also in Egypt, either prophylactic or therapeutic for lymphedema prevention. So we moved from axillary clearance sampling essentially, no nodes at all, prophylactic lymphovenous shunts or lymph node grafting. Current surgical practices, please, the standard is conservation. Consider oncology safety above cosmetic surgery, offering reconstruction to all regardless of their age or education. Multidisciplinary approach, no surgery without a core biopsy. Breast care nurses are mandatory here. Now, the physicians, the medical management, over the years in 1923, they started to relate cancer occurrence with the number of pregnancies, with the menopausal status. Landmark years here. Hormone manipulation in 1895, ovarectomy was practiced. In 1951, adrenalectomy, removal of the pituitary. A couple of years later, ER receptors were diagnosed or discovered in 1967. These are landmark years for all of us. Tamoxifen was licensed to be used in 1986, and that was a single drug that had changed the management of breast cancer. HER2 receptors were discovered in 1984, and Herceptin was licensed in 1998. These are very important days. CDK4, this is the fashion of the last couple of years. CDK4/6 inhibitors, cyclin-dependent kinase 4 and 6 inhibition was really important. Now we have the Ibrans, we have the Verzenio available. We can use it with hormone therapy, and that also have changed significantly the outcome of ER-positive, HER2-negative breast diseases. BRCA1 and 2 were reported in 1994 and 95. And again, they were very important discoveries. Z11 study, we all know about it, 2011. It was started in 1999 and reported in 2011, followed by the Amarus axillary nerve ablation or surgery in 2014. The PDL1, which is a very important discovery. And actually the people who talked about it, Allison and Hondier, they won the Nobel Prize for discovering it. And we discovered that if we can control that PDL1, we can inhibit this, we can improve the triple negative outcome. But it's pretty expensive. So continued advances were really moved on. Response modulators, Oncotype DX, CDK4/6, PDL1 immunotherapy, immune check inhibitors, radiation therapy changes. So we talk about chemotherapy. Chemotherapy started in the 1980s, adjuvant or neoadjuvant or palliative. We started with the CMF. Unless you keep up, you find that the regime are changing. Started with the CMF 4 sessions, and then FEC or AC 4 or 6 sessions. Taxanes came into equation, AC, 4 sessions or 3 sessions, then we moved to taxanes, and no, AC plus taxane, and if it is HER2 positive, give her Herceptin. Why not go for TCH, taxane, carboplatin, and Herceptin? No, why don't we add Perjeta to the equation? Now we have the Herceptin and Perjeta combined into Visco. So there are a lot of change in the medication at a very costly effect, at a very high cost, yet very significant improvement in outcome. The immune check, as we say, the PDL1 testing, programmed cell death protein legend, which is Keytruda, but it's pretty expensive. The 100 milligram vial is 71,000 pounds, yet it improved overall survival by almost 7 months. CDK4, we talked about the Ibrans and the Verzenio in combination with hormone therapy. chemotherapy planning used to rely on the TNM classification, but no, we came up with a Nottingham prognostic index where we only took into consideration the size of the tumor, the grade of the tumor, and the nodal status, and then we came up with our own adjuvant online. You can put the data and give you roughly estimated survival or relapse disease, and then we predict NHS. We all use it now. This is a bit of a summary about the NPI, and I practiced it maybe until 10, 15 years ago. Although I started in 1987, and now the Predict NHS, we took into consideration the menopausal status, sign, grade, node, HER2 status. The Van noise for the DCIS that was described in 1996 and took into consideration 4 things: the age, the grade, the margin, the size of the tumor, and that helps you a lot in planning management of a DCIS. The Van noise from South California University, the DCIS there. And then radiation. Now we're moving into radiation. Radiation therapy. There was Conrad Rentgen. He actually won also a Nobel Prize for this. He talked about the effect of radiation on tumors, and this is the Wilhelm guy. Radiotherapy in 1895. Wilhelm Conrad Rentgen, Nobel Prize awarded to him in 1901. Proton beam in the 40s, tangential field fractionation, hypofractionation, 5 doses only at the time of the corona, 3D gating, IMRT, IORT, palliative, only after conservative surgery, after mastectomy, if 4 nodes, no. After mastectomy, if it is only single node as well nowadays. So that's changing very fast. What's IORT? Intraoperative radiotherapy. It needs a lot of very expensive setup, but again, it's useful for a small, relatively small tumors, node negative, but needs a very expensive setup. Diagnostic radiology, now that's very important. Diagnostic radiology has changed the game, and they are our hope now, not the surgical intervention, not the medical intervention, it is the radiology improvement. In 1913, Solomon started talking mammography. In 47, we started to improve, and nowadays the practice after Price in 1970 until now, it is fantastic changes. We have analog mammography, moved to digital mammography, tomosynthesis, contrast enhanced digital mammography, all are aiding the diagnosis. Diagnostic radiology, as we talked about it now, ultrasonography, actually described by Army surgeon in 1951 when he diagnosed 2 tumors by ultrasound. And then MRI in the 1980s conceived PET mammy nowadays practice. And we have at least 3 centers in Egypt who can do PET mammy. And I think it is fantastic improvement in early diagnosis and management. FNA, core biopsy, mammotome, breast lesion excision, localization. This is the classical mammogram, ultrasound, and this is the MRI, and this is the PET mammy. It's just fantastic in depicting tumor. Now, there is a common question here. And you hear a lot about the medical people saying surgery is going to be just a medical, breast cancer treatment to be just medical. We're going to get chemotherapy, tumors wither away, and no need for surgical intervention. So that's a common question we hear it a lot in meetings now. Will surgery be part of the past and the treatment will be medical? I would say, I see it, or hope it will be only surgical treatment, with continued awareness campaigns and solid screening programs that could diagnose cancer at a very early stage, then minimal surgery will be all that is needed. We have had a lot of improvement, but we're still lacking here, unfortunately, in Egypt, the psychological aspect.
يعني البنت كده في مرة انا عايزه اسالها عايزه كان معايا بس مش معايا العينه وعايزه اسال المساعده بتاعت الدكتور كانت لو هي تمام ان احنا قلت لها والله اتفضلوا معاك العينه لان احنا عندنا مره كده انا مع ان انا بتاخد كل حاجتي بس زي ما الدكتور قال انا قاعده مستنيه اكتر من 2 3
كان عندي امبارح مريضه في العياده وكانت بتتعالج في مركز ما من المراكز الكبيره في مصر، وجايه تشتكي بتقول لي انا عاوز حد يشرح لي، اصل ما فيش حد بيكلمني في العلاج، وما باجي اتكلم المريض تقول لي يلا يا ماما اطلعي علشان ما عندناش وقت عندنا عيانين كتير غيرك. That is a vital part in treating patients, please. We really have to support the patients psychologically, give them time. There's nothing called يلا يا ماما ده عيانين كتير بره. I hope المراكز الكبيره في مصر زي ما احنا عملنا في بهية ياخدوا بالهم من النقطه دي. Thank you very much.
Dr. Ashraf, can you just stand for a minute? I just like to thank you for keeping time. Thank you again for this comprehensive historical background, which needs many lectures to illustrate it. We can take one or two comments or questions, and we will move on. Asalo?
Thank you very much, Professor Ashraf. Thank you very much. Really enjoyed it. Just a little comment. In one of the Egyptian temples, there was an inscription of a woman with one breast. It's nothing enough is written about that, but it's well seen in one of the temples in Luxor, about a lady with one breast. Maybe they did mastectomy. There is no proof about that, but there is an inscription that showed that quite clearly. Second, I would like just to comment that mammography really started, as you just mentioned, with the analog, but before that, there was the contact mammography, which uses just a film in an envelope direct to the breast. It's industrial film, and that was the beginning. And also the zero mammography. I just want to add more about that, and that would be all my comment. Thank you very much. I really enjoyed it. Thank you.
حضرتك تقديم الدكتورة هبة.
Bismillah ar-Rahman ar-Rahim. I had the honor to join this scientific gathering, great gathering. It's the first time to attend the Baheya conference. في الحقيقة, I have to congratulate all the team. الخدمة المجتمعية اللي بتقدمها بهية كلنا كأساتذة أورام لمسنها، فأنا بشكركم جميعا على المجهود الرائع والتأثير الإيجابي المجتمعي لبهية. Now, I have the honor and the pleasure to introduce my dearest professor, Professor Dr. Heba Zawahri. Professor Heba Zawahri is an eminent figure in the field of medical oncology. She is my role model. Dr. Heba will tackle a very important topic related to advantage and disadvantage in neoadjuvant treatment in early breast cancer. The floor is yours, my dear sir.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Mr. and Mrs. Chairman, all the dear professor and colleagues at the board, again and again, I am pleased and honored to be in this scientific session of the 6th Baheya conference. Thank you, Dr. Amanitet, for your kind invitation. Thank you, my dear student and my dear son, Professor Meher Hassan. Meher Hassan, okay. Thank you, Dr. Meher Hassan. أشكرك على كل المجهود وأشكرك على وأشكرك على كل المجهود علشان تعمل هذا المؤتمر الضخم. Very shortly today, my presentation will be a little bit astonishing to all of you. Every day I'm talking about the benefit and the effectiveness of the neoadjuvant, and I am a big supporter to all surgeons. Please come and discuss with me and don't touch the breast before doing some neoadjuvant. But today, in the contrast, I will criticize myself or criticize what's happening in the last 20 years, and we would like to revise with you, is neoadjuvant is completely safe? And is any disadvantage of doing some neoadjuvant? This is a little bit a philosophic approach for adjuvant and neoadjuvant. And why is that? We are convinced that breast cancer is a systemic disease, And it is from the early beginning, there is a spread of some cells to have metastasis later on, or to infiltrate the lymph node, or to be dominant for many years and then present as metastatic disease. And why we are thinking of this, and that is why we would like to treat it systemically. We would like to give some drugs and some chemotherapy early beginning. And this is happening in the adjuvant setting and the early adjuvant trial, assuming that after complete evacuation of the breast or complete surgical treatment of the breast and radiotherapy, we still convinced that there is a hidden cell, and then we give adjuvant. So the idea started to be, why not to give it early beginning, even before touching the breast, and we are supporting for a neoadjuvant. So neoadjuvant started as an idea to bring the inoperable cases, inflammatory breast cases, to be operable. And then we are more to have a conservation, and we would like to have less axillary evacuation and or less axillary surgery. So we started to apply to a large tumor, and then now it is almost indicated for many types of tumor. We are doing this many years ago, and now the umbrella for neoadjuvant, like everybody go and take some sort of neoadjuvant, and then we will discuss how much the tumor decrease in size, and we will advise the patient for what type of surgery. But while we are doing that, we discovered that large randomized trial thinking of neoadjuvant versus adjuvant indicates that equivalent disease-free survival and overall survival. So we obtain a good reduction of the tumor, good reduction of the axilla, but when we started to compare by those patients who didn't receive neoadjuvant and received only adjuvant, it may be 10 years or 15 years, the end result is same. So we started to think about too much toxicity and adding a combination early beginning, and then may patient need some adjuvant, again toxicity. This is better, or to de-escalate the chemotherapy and de-escalate the neoadjuvant approach. Okay, and what has happened that in a very simple old trial, they started to think of giving chemotherapy upfront, and they discovered that this naive tumor responds marvelously to chemotherapy. We can obtain 40% of our patient reduction or complete disappearance of the tumor pathologically just because chemotherapy. And this is not only reduction of the size, but it projects on that who is working better than other. They started to see a curve of patients who enter in complete remission, living better with less event for metastasis or disease-free survival and less local recurrence than those does not enter in complete remission. But here, please think with me. Everybody can set the same on the slide, but in this curve, there is no comparison between patients who didn't receive the neoadjuvant and received it only on the adjuvant on the long disease-free survival and overall survival, as if they are segregating the good and the bad. When giving chemotherapy upfront, وكأننا بنختار الناس الكويسين دخلوا in remission and they will live for a long time, والناس الوحشين or they have a bad pathology. لكن ما قارناش bad pathology and the good pathology if not taking a neoadjuvant, and this is again a new approach. So what is the disadvantage and why you are seeking like that? Is there is need for further chemotherapy, and this is appear now in the recent publication for patients who do not enter complete remission. We refer to them as residual disease. This residual disease may be a problem to all clinicians and all physicians or all the breast treatment group, because this residual disease, first of all, there is a very long time between presentation, so it may have some metastasis. Again, it exposed to chemotherapy, so some cells are mutant or resistant, and then the patient harboring the disease for months, and we have to give her a good treatment for this residual disease that may, and nowadays, be immunotherapy, targeted therapy, and genetic therapy of hormone inhibitor as well. So this may represent how much we treating in the neoadjuvant, but we cannot cure 100% of the patient. So less than CR is a problem to us nowadays. Okay, and is this translate to much toxicity and late side effect? You know that overexposure of cytotoxic drug may later on 10 years ago patient have leukemia or bone marrow suppression. Non-responding patient making us a pending question. So what is the type of surgery if she is a little bit decreased or non-responding? How far adjuvant treatment will cure those non-responding patients? And now, in the old day, they give more and more. They started to give, either we give 3 or we give 6 before surgery. They give 6. And when they give 6, نفسهم اتفتحت أكتر. They have a more response. So, and this is the old biology. So just by giving 6 or 8 cycles of cytotoxic drug before surgery, we can obtain 65% complete remission, clinical complete remission. The disease disappeared for us, for the patient, and for radiology. So if this is good or bad, now they include a better prognostic group of patients, not negative, and they respond because the disease is naive and the tumor is very sensitive. So high percentage of pathological CR make us a dilemma. What are appropriate surgery if not clipped before this procedure? Shall we give her modified radical mastectomy as if we are promising the patient something good, but we are not tickling it properly, so the end will be again mastectomy? Is axilla dissection to what extent when the patient completely have nothing in her axilla? And which patient in PCR can omit surgery at all, as mentioned by Dr. Ashraf in his last line of the slide? Can patient who enter a complete clinical, radiological, and many biopsy can omit surgery? Can breast cancer treated only medically or by some radiotherapy? And there is now Italian group of study that provocative or support this method of treatment. So why I'm talking about the disadvantage is neoadjuvant chemotherapy for breast cancer, which benefit. We have to do patient selection and biology selection, not for everybody. Is it time to rethink about this advantage of the neoadjuvant? This is not my word. This is in the Lancet in the year 2018, when they looking for a meta-analysis of 6 randomized trials that contain 4,700 something women. And they started to look for every detailed patient who received neoadjuvant versus adjuvant, and they discovered that breast conservation, of course, is more for neoadjuvant, but please, the second column, the second row, local recurrence after 15 years represented 21% of the patient versus 15% with significant B value. So patient who subjected to neoadjuvant, whatever type of surgery, can show local recurrence later on. Disease distant recurrent after 15 years, 38.2% versus 38 non-significant. Same balance. Breast cancer mortality, 34 versus 33. So we are doing neoadjuvant not to perform a good overall survival, and maybe in some study not to perform a disease-free survival, but we may give the patient in certain conditions a higher local recurrence. So this is in the same curve. This here in the same curve. The number is the same curve, and this is from the early breast cancer trials collaborative group. This is a very respectable analysis Usually, they do this analysis every 5 years from all European centers, and the data from this collaborative group is very respectable everywhere. So here on the first curve, there is a definite increase in the local recurrence, while here time set trial only, here the breast cancer mortality very similar, and the breast distant disease recurrence very similar. So the conclusion is local recurrence after breast conservation surgery after neoadjuvant chemotherapy should be considered carefully. Please discuss with the patient, please discuss with the surgeon, please discuss with the biologist and the pathologist, because we have to do more tumor localization, detailed pathology assessment, and appropriate radiotherapy may help to minimize this long-lasting local recurrence. This is again repeated in the study in the year 2020. And this, they bring all German group trial, 9 groups from the breast cancer, German breast cancer group. And they started to look for local original recurrence risk after, what is the risk to have this local recurrence after neoadjuvant? A pooled analysis of 9 prospective neoadjuvant breast cancer trials. And they collect 10,000 plus women with primary breast cancer from 9 trials, and the main outcome to look for local recurrence as the first event after neoadjuvant treatment, distant recurrence identifying local recurrence predictor. Is it surgery, pathological complete response, or breast conservation type or other potential risk? They found that after a median follow-up of 67 months, local recurrence was 9.5% in patients who have pathological CR. But it is more, or multivariate analysis identifies that it is more in younger age, clinically positive lymph node, GT tumor, grade 3 tumor, non-pathological CR, and the triple negative breast cancer. So those group of patients, we are very willing to bring them a conservation while they may show some local recurrence, but not the surgical type. At the conclusion, this pooled analysis demonstrates there is a clear need to investigate better multimodality in the post-neoadjuvant setting for high risk. Is it less radiotherapy? Is it less follow-up of the patient, or it is maybe a safety margin as well? So what has happened? This is the progress of the application. This is the progress of application of neoadjuvant. We start maybe 20 years ago, like fighting. A medical oncology fight every day with the surgeon. Please don't touch the breast. It is like fighting between us and the surgical oncology. After the maturity of many clinical trials and the more recognition of the pathology, and we have many drugs for anti-HER treatment and for triple negative treatment, we started to convince, not we, the literature and the mature clinical trials started to convince the surgeon and the group who treated the patient that we may have a good neoadjuvant according to biology. And then the maturity onset comes when everybody calls for MTT. So we are calling for, let's sit together and discuss what is best for the patient. And once we said that, we bring the pathology paper and start to read it in detail, and nobody can put his decision for this particular lady until we saw the pathology, lymph node, and the biology as well. So doing that, we described and we know some cases that will not be touched by neoadjuvant at all. And this is not my recommendation. This is the ESMO recommendation in the Annals of Oncology. Luminal B, luminal A, breast cancer patient better not to be touched or will not be benefit of any chemotherapy, and just go straight forward and do operation or give her endocrinal treatment for not less than 4 to 8 months. طبعا دي حاجه هتسعد الجراحين جدا ويقولوا اول مره دكتوره هبه بتتكلم لصالحنا بس this is a recommendation. Okay, for anti-herpes treatment we have many trials and we now pass through a phase of escalation. You put dual inhibition for anti-herpes treatment, and by this we reach a higher pathological CR. But look with me on the curve, there is no benefit for addition of pertuzumab over trastuzumab after 5 years of treatment. The curve is just attached to each other, and this is one of disadvantages. When we give a cardiotoxic treatment to the patient, we saw a very good result, almost described by melting of the tumor, but on the long benefit effect, it is the same. And here is a very important slide that summarizes what's happened in the story of HER2 treatment or target treatment. You will see in the first group of the column, patient who received bevacizumab, for example, versus the placebo, and we obtained 39 pathological response versus 26%. This is the very early phase of the disease. But look, after 5 years, the disease-free survival, which is adjuvant drug, while the patient alive, and the yellow one adjuvant placebo alive. So both are very similar to each other. Here in Neo Alto trial, when we give lapatinib and trastuzumab, the pathological CR is higher. But again, disease-free survival and overall survival same after many years. In the NeoSphere trial and the affinity trial, when we give dual inhibition with chemotherapy, we give pertuzumab, trastuzumab, taxanes, and the carboplatin. So the patient in early stages, she must receive the 4 cytotoxic drugs and continue 2 of them for 1 year. You have to imagine the pressure or the toxicity. It brings us a higher pathological CR, but the disease-free survival will be this. So triple negative now is very complicated. Triple negative, you have to know her BRCA mutation, you have to give her carboplatin. Of course, you have to think about immunotherapy, all to reach a very good pathological remission. But as I said to you, neoadjuvant is good. And we saw the result, but the residual is a problem. Problem for everybody, problem for the patient and problem for us. And many literature now are talking about the residual. Before you think of giving too much drug and you think for pathological CR, think how you will be treated if you face a residual of this triple negative or HER2 disease. And this slide, I put it just to remind yourself, to remind myself and to remind you, this is the residual. And everybody now working not hard to enter the patient in CR, we achieve a good in that. But we are thinking, our medical literature thinking of giving residual. For example, هقول لكم قبل ما اخلص التريبل نيجاتيف اللي مش هيدخل في الريزيدوال هياخد كابسايتامين وهياخد بارب انهبيتور لو عنده ميوتيشن وهياخد بيمبرولوزوماب لان هو استفاد منه. For how many years? For at least 2 years. So the residual now is a problem. And I put this networking for a guideline to treat triple negative to complicate the thing for me and for you. So it is very complicated thing. لا ثانية واحدة. أقل من ثانية ما تقطعش عليا. أقل من ثانية. هو السلايد الجاية لا قبل ثانية بقى خليك حلو. Judgment and conclusion. أول مرة نتكلم عن disadvantage. صح؟ أنا أكثر واحدة بحب النيو ألفا. طيب أمال إيه؟ We have to think carefully by biology. We have to think carefully. العين عندها 70 سنة ولا 35 سنة. We have to think. She had a huge pendulous breast and will not receive the radiotherapy وزنها 117 كيلو ولا she is thin and have small breast. Still, we have to advocate and we have to repeat that neoadjuvant allows more breast conservation, of course, provide information about the nature of the disease, of course, increase the response by more chemotherapy. We now in the era of escalation or de-escalation, increasing disease-free survival, but not an overall survival in some study. Neoadjuvant chemo is associated, of course, by increase in the local recurrence. وانا بدعو كل المراكز ان هي ترجع 5 سنين او 10 سنين وتشوف اللوكال ريكرنس بعد النيو ادجوانت ايه. It appears that better disease survival, disease survival, or overall survival. Thank you very much.
Dr. Heba, as usual, a very comprehensive, elegant presentation. Thank you, sir.
So I have the pleasure now to introduce to you one of the very eminent radiologists, and I will not be talking on her efforts in Baheya. You know her better than me in this regards, but I will tell you about her full dedication to breast imaging over maybe, I don't want to make her looks older, but maybe 25 years or so in dedication. And she was the former head of the women's imaging unit in Qasr Al Aini Hospital. And she was the former director of the early detection of breast cancer of the national project. And of course, a dear friend to me and a dear colleague, and I know that she has a very, very way of expressing her lectures, and I'm sure we'll all enjoy her presentation. Dr. Rasha Kamal, Professor of Radiology, Qasr Al Aini.
شكرا يا دكتور أشرف. شكرا. بسم الله الرحمن الرحيم. In breast imaging, it is challenging enough to be able to diagnose the underlying cause behind breast symptoms. Yet the biggest challenge is how to apply the best practice to do so. And to do so, we must be able to choose the most appropriate imaging modality, and we must be able to correlate what we see in this imaging modality with the clinical the breast imaging cycle usually starts by a patient, symptomatic or asymptomatic, is referred to a clinician. The clinician orders a specific imaging modality. He sends the patient to the radiologist. The radiologist writes the report and returns it back to the patient. Usually, this breast imaging cycle should go on smoothly, but sometimes it becomes disrupted when a clinician orders the wrong exam and when the radiologist asks for unnecessary additional examination. And with the exponential increase in breast imaging modalities, it has become essential for clinicians and radiologists to be aware of the indications, advantages, disadvantages, and appropriateness criteria of using these new modalities in order to keep the breast imaging cycle going on as well. And in this lecture, we're going to highlight how we can incorporate the modern mammography techniques in the diagnostic workup of some common clinical scenarios. These techniques are namely the tomosynthesis, the contrast mammography, and the PET mammography. Before we do this highlight, we have to understand how these modalities operate. And we start with treating digital tomosynthesis. Tomosynthesis is exactly like the mammogram, where the breast is placed here in between the compression plate and the digital detector. What's different from a mammogram is that the X-ray tube moves in an arc across the breast, taking a series of low-dose images that are acquired at different angles. The total dose is similar to or slightly higher to a single new breast exam. The end result is that we have a reconstructed 3D image, exactly like what we do in CT. We can view now the breast every 1 millimeter. We can imagine if this is a breast which contains microcalcification, an area of parenchymal distortion, and a speculated mass lesion. If we just compress all over each other, and like what we do in mammography, this is how they will appear, and we will be unable to characterize any of these lesions. While if we go slice by slice in the breast, a slice will pass through the microcalcification, another through the parenchymal distortion, and the third one through the speculated mass lesion. And now we can characterize each lesion individually. In the field of breast imaging, the best results are usually obtained from modalities which can combine an enhanced morphology assessment together with providing some functional information about the tumor cells. What tomosynthesis plays in a role is the enhanced morphology assessment, but it does not give us any functional information about the tumor cells. And that's why we move to the second modality, and this is the contrast enhanced mammography. The technique of contrast mammography is somewhat similar to MRI, where we inject contrast media in order to highlight areas of concern within the breast. In each mammography position, we take a pair of images. The first is a low energy image, and this is exactly like the mammography. It has the advantage that we could still see the microcalcifications. The second image is a high energy image. It's not a diagnostic image, but it is used in the post-processing to give us the recombined image in which everything is cancelled except for the area of which has updated the blood. It is true that contrast mammography plays a role in enhanced morphology assessment, and it gives us some functional information with the injection of contrast media, but yet there is significant overlap between the enhancement patterns between benign and malignant lesions. And now we move to the third modality that we're going to discuss today is the positron emission mammography. While interpreting the positron emission mammography, or what we call PEM, the images are displayed as 12 slice tomographic slices, and they can be viewed either in the grayscale or in a color-coded scale. When we come for interpretation, we do both a qualitative assessment, exactly like what we do in MRI and contrast mammography, and the quantitative assessment, exactly like what we do in PET-CT. PEM helps us to characterize, localize, and locally stage breast cancer. For example, this patient, she has acute carcinoma in the right breast. Looking at her breast, we can neither identify where the carcinoma is, the size, and the relation to the surrounding structure. While with a simple look at the PEM, we can now identify that it is not a single carcinoma, it's a multifocal malignant mass lesion. We can measure the size and know the relation to the skin and the blood. And now we go back to our stations or clinical scenarios, and our first station will be with screening. I always say that in screening, we usually follow the traffic lights, where we can classify the female population into an average risk population with no specific risk of developing breast cancer. The moderate risk have an increased incidence, 15 to 20% more than the general population to develop breast cancer, and the high-risk population have an incidence of 20 to 25%. For the average risk and the moderate risk individuals, we start mammography screening, contrast mammography, although it has the potential to be used as a instead of doing mammography and MRI, yet up till now we have no sufficient data to verify its use as a primary screening modality, and up till now it is used on report. We have this asymptomatic woman. She joined the screening program. She had this mass lesion in the right breast. It looked more or less benign. But things were not the same when we looked at the tomosynthesis images. It is a speculated mass lesion, which was biopsied and turned out to be an invasive carcinoma. This is another screening mammogram of a moderate risk individual because of her heterogeneous dense breast parenchyma, and she had a subtle asymmetry in the right breast. And when we say asymmetry, it means that we see a lesion which is not a mass, and there is no corresponding lesion in the contralateral breast. We targeted this area by an ultrasound examination, and there was an underlying hypoechoic area, mass lesion, and we biopsied this lesion, and it turned out to be an invasive lobular carcinoma. Having an invasive lobular carcinoma in such a dense list makes us do another advanced imaging modality, either contrast mammography or MRI. And in this case, we did contrast mammography. And again, because of the subtle changes of lobular carcinoma, we see very subtle enhancement corresponding to the lesion that we have biopsied. But at least we can exclude the presence of any other contralateral or even lesions within the same breast. We come now to the second station, and this is breast pain or mastalgia. Mastalgia is a common symptom experienced by up to 80% of women at some point in their lives. It is either non-cyclic or cyclic, and it might be either focal or diffuse. If we have non-cyclic focal mastalgia, further imaging is appropriate to exclude underlying pathology. While if we have cyclic diffuse mastalgia, further imaging other than regular screening is inappropriate. Mammography is often used to evaluate breast pain, and in most cases, no imaging correlate is found to explain the cause of breast pain. And when clinicians insist on imaging evaluation of breast pain in the presence of negative clinical examination, this increases unnecessary additional imaging stuff. And this is one good example. She's a 35-year-old female with cyclic mastalgia more on the left side. On examination, nothing was comfortable. This was her mammogram, and there was a subtle asymmetry in the left breast. Yet when we targeted the area, there was underlying focal fibroglandular parenchyma, and the axillary lymph nodes were non-specific. We wrote the report that this is focal adenosis, and we recommended that the patient should be put under a close follow-up. Her clinician insisted that we do a contrast mammography, and it is normal if we have fibroglandular tissue condensation to find some subtle enhancement of this fibroglandular parenchyma. He insisted to do a biopsy, and the biopsy came back with focal fibroadenosis. We move now to the third station, and this is the palpable mass station. A palpable breast mass is one of the most frequently encountered clinical complaints, and it is one of the commonest presenting features of breast carcinoma. In general, cancers presenting as palpable lumps tend to be more aggressive. In a palpable breast mass lesion, we usually look at the patient's age, if she's above 40 years or below 40 years, or if she's pregnant or lactating. Above 40 years, we should start with a mammogram, and it might be complemented with an ultrasound, MRI, or even a biopsy. Below 40 years, lactating or pregnant, we should start with an ultrasound examination, and according to the findings, we might recommend for further mammography, MRI, or biopsy. Usually, no additional imaging in most of the cases is needed other than mammography and ultrasound. Then when are modern imaging technologies indicated? They are indicated to identify lesions not seen on mammography, to confirm the benign or the malignant lesions, nature of these lesions. Whenever we have a dense breast parenchyma, whenever we suspect lesion multiplicity, and to know the actual size and extension of lesions. This is a case with bilateral circumscribed mass lesions. Are they benign or malignant? We cannot decide this on the mammogram. While looking on the contrast mammography, the lesion on the left showed heterogeneous enhancement. There was an additional lesion anterior to it, anterior introductal extension reaching to the nipple. A biopsy was taken, and this was a triple negative breast cancer. The lesion on the left did not show any contrast uptake, and it was simply a fibroadenosis. This is another 30-year-old lactating female with a palpable left upper outer quadrant mass lesion. Because she's young and lactating, we started with the ultrasound examination, which showed a hypoechoic, highly vascular mass lesion. We recommended for a mammogram, and we revealed an obscure mass lesion, and we recommended contrast mammography in this case to exclude the presence of other lesions, and because the pathology came back with a triple negative breast cancer, so we had to have a baseline before she received neoadjuvant chemotherapy. After she completed the neoadjuvant chemotherapy, she came for re-evaluation, and there was complete radiological response. This is another 64-year-old female with a left breast mass lesion. She has renal impairment. And whenever we have renal impairment, we cannot recommend for contrast mammography or MRI, and our only alternative is the PET mammography. She had a mass in the left breast. It appeared on ultrasound, and we suspected the presence of contralateral lesions as well. According to the MDTE, they recommended for a further contrast study to identify the extent of the left breast mass lesion and to characterize the right breast lesion. Because she had renal impairment, we performed PET mammography, which showed that there are no lesions on the right side, while on the left side, she had an upper outer quadrant lesion with anterior intraductal extension, and there was another smaller lesion. So this case was a multicentric invasive duct carcinoma, and she had a normal benign right. Now we move to another station, and this is the nipple discharge. Nipple discharge is again a common clinical complaint. It might be physiologic or pathologic. Physiologic nipple discharge is bilateral, multi-orificial, occurs on squeezing the breast. It is milk, green, or yellow, and may accompany ductectasia, mammary adenosis, or some inflammatory lesions. The pathologic nipple discharge is usually unilateral, uniorificial, spontaneous, bloody, and usually due to intraductal papillomas, sometimes also with malignant mass. So whenever we have a patient, we have to examine the nipple discharge, decide whether it is physiologic or pathologic. Physiologic, in physiologic nipple discharge, no specific imaging is needed other than regular CT. For pathologic nipple discharge, we have to do a sonomammography, and only if negative should we proceed to other imaging modalities. This is a case with a uniorificial bleeding per nipple. She had multiple lesions present, linearly distributed in the left breast. Her clinician recommended for a contrast mammography, which added nothing more. The lesions were looking the same as they appeared on the mammogram. While looked on the ultrasound examination, we can easily identify the intraductal location of these lesions. And actually, ultrasound is the best physiologic, best modality in physiologic and even pathologic nipple discharge. It helps us say whether the patient has simple ductectasia with retained secretion, with associated periductal mastitis. It can also diagnose intraductal papillomas with the characteristic central vascular pedicle and intraductal malignant mass lesions, and it can differentiate both from inspissated secretions within the duct, which appear separate from the duct walls, and avascular. Now we come to the last station, and this is mastitis. The term mastitis is often used synonymous with breast infection, but strictly speaking, mastitis is inflammation of the breast irrespective of the host. The inflammatory breast lesions encompass a wide variety of breast lesions, starting from the simple mastitis, which is treated with antibiotics and hot fomentation, up to the inflammatory duct carcinoma, breast carcinoma, which is treated by neoadjuvant chemotherapy and mastectomy. And to reach an accurate diagnosis often entails repeated unnecessary biopsy. Again, ultrasound takes the upper hand in diagnosing mastitis because we have the ultrasound signs which favor benign breast inflammatory lesions. And these include the edematous echogenic papillae that are surrounded with ill-defined collections. The skin thickening is usually not remarkable like the malignant condition, and we might find actual abscess cavities within the breast. And when we look at the axillary lymph nodes, they are reactionary nodes with reserved fatty height. At the same time, we find no malignant mass lesions, and there are no dilated subdermal lymphates. While we also have other signs which favor that this inflammatory process is a malignant process. Again, we have echogenic fat, but this time it is not surrounded by fluid, it's just interstitial edema lines. There is a dilated subdermal lymphatic, marked skin thickening. We might find mass lesions, and the axillary lymph nodes are pathologic. In the same time, we see no collections and no abscess cavity. Unfortunately, we sometimes have atypical ultrasound features like increased parenchymal vascularity, abscess cavities which mimic solid mass lesions, and sometimes we have indeterminate axillary lymph nodes. And in these cases, we fall in the dilemma whether these lesions are benign or malignant. And only in these cases should we proceed for further imaging. And when we say further imaging, it is okay to proceed to an MRI, but please never in an inflammatory breast proceed for tomosynthesis or ultrasound. This is a lactating patient with right breast inflammatory changes. She had multiple irregular hypoechoic mass lesions in the breast. A mammogram was requested and it revealed the global asymmetry of the right breast, which means the right breast is denser. She had pathologically looking axillary nodes, indeterminate upper outer quadrant microcalcifications, and she was assigned a virus post. This was her tomosynthesis examination, and it added no information at all. While with a simple look on the MRI, we can now recognize there are multiple abscess cavities in the breast, which appears right in the T2 weighted image, and this was simply a case of multiple abscess cavities in the case of granulomatous mastitis. If we look at these two cases, we have a global asymmetry of the left breast in both cases. And when contrast mammography was requested, in both cases, there were malignant-looking mass lesions. While the pathology report of both cases, the first case was simply a granulomatous mastitis, and the second case was a periductal mastitis. So to make sure, again, please do not recommend contrast mammography whenever you have a patient presenting with inflammatory breast. To wrap up what we've been saying, for an asymptomatic woman, she's asked to go for a regular sweeping mammogram. If we have tomosynthesis, it should be incorporated in at least one view, because it increases the detection rate and it increases the recall rate. If we have ultrasound, automated breast ultrasound, they are usually recommended for dense breast, for further characterization of detected lesions, and contrast mammography and MRI are used, have the potential to be used in high-risk individuals. If we have a symptomatic patient, we either start with ultrasound or mammography according to her age, and usually they are enough. Ultrasound takes the upper hand whenever we have intraductal lesions and in cases of inflammatory breast lesions, and contrast mammography and MRI are resorted whenever we suspect multiplicity, multiplicity, or to identify the extent and some of the range. In the last decade, we have witnessed an intense increase in the volume of breast imaging techniques with the development of new technologies and the upgraded application of already existing ones. These new breast technologies are meant to enhance the evaluation of patients with breast problems by ruling out the presence of breast cancer and at the same time addressing the patient. Yet the challenge will always remain: how can we achieve this goal by using the right modality in the right time and for the right purpose?
Thank you very much, Professor Rasha Kamal, for your شور تفضلي.
هو في ان شاء الله في الدور الاول يعني اكروس كده هتلاقوا في اسانسيرات، هنطلع الدور الاول في ورك شوب ارتفيشال انتليجنس، ورك شوب كونتراست ماموجرافي، وبكره هيبقى في ورك شوب MRI. اللي عايز يشترك يطلع يسجل اسمه في الوقت، كل ورك شوب هيقعد لمده ساعه، فاللي عايز يطلع يسجل اسمه ان شاء الله.
Thank you again, Professor Rasha Kamal, for your usual exquisite presentation. Thank you very much. We'll postpone the questions till the end of the session.
Now I will present my dear friend and one of the most famous oncosurgeon, Professor Sharif Naguib. He's professor of surgical oncology in the National Cancer Institute, Cairo University. His talk is about multiple lumpectomies for minimally invasive breast cancer. I would like also to thank the organizing committee for inviting us for this elegant conference, especially Professor Rasha Kamal, Professor Maher Hassan, Professor Amr Farouk, and Professor Ashraf Zayed, and all the organizing committee and the staff member. Thank you.
I would like to thank the organizers of this very impressive Congress. I would like to thank Dr. Professor Amani Hilal Professor Rasha Kamal, and definitely Professor Maher Hassan, who is my dear friend and colleague at the National Cancer Institute. I will be trying to give an idea about the new concept in breast cancer surgery, which is multiple lumpectomies for multiple ipsilateral breast cancer. My name is Sharif Naguib. I'm a professor of surgery at the NCI breast unit in Cairo University. Now, the term multiple ipsilateral breast cancer can be divided into two separate entities, either multifocal disease or multicentric disease. Multifocal disease means two or more tumor foci that are present in a single quadrant, or the distance between them is less than 5 centimeters. While multicentric disease includes two or more tumor foci that are present in different quadrants and that are separated by a distance that is larger than 5 centimeters. Standard treatment for multifocal disease nowadays is partial mastectomy with safety margin all around these tumors, including the whole malignant foci, while standard treatment for multicentric disease until today is mastectomy. Now, what about the instance of multiple ipsilateral breast cancer, whether multifocal or multicentric? Well, it has been shown to be found in up to 60% of mastectomy specimens. In the recent study by Winters, it was shown to be around 25%, which is a little less. And the identification of these entity is increasing with the use of more accurate and sophisticated imaging techniques like contrast-enhanced mammography and MRI. Nevertheless, these techniques, even if they detect many cases of multifocal multicentric disease, they cannot detect them all, and hence the necessity of adjuvant radiation to ensure local control. Now, when did the idea start? The idea of breast conservation for multicentric cancer started almost 50 years ago by the NSABP P6 study in 1985, where Bernard Fisher found that when he compared total mastectomy to lumpectomy in breast cancer, in 1,800 breast cancer patients, he found that both had the same disease-free survival and the same overall survival. Now, if mastectomy and lumpectomy have the same disease-free and overall survival in these patients, how many of these had multicentric disease? Actually, maybe 8 or 9 years before this study, another study had found that focal multicentric foci of carcinoma amounted for 20% in mastectomy specimens. So Bernard Fisher had probably 20% of his patients who had focal multicentric disease, and still both who had mastectomy and lumpectomy gave the same overall survival and the same local recurrence rate. So in unifocal breast cancer, it is known that mastectomy and breast conservation give same results. But in multifocal and multicentric breast cancer, and especially in the early 80s and early 90s, many studies proved that breast conservation could not be done for multifocal disease or multicentric disease, and that they had a very high rate of local recurrence if breast conservation was tried. So mastectomy was the standard treatment for multifocal and multicentric disease for many years. Nevertheless, these studies were criticized because of many factors. Number one, they had inadequate number of patients. Some of them had 10 patients, some of them had 10 patients, some others had 13 patients. These studies lacked routine advanced imaging techniques. They didn't use targeted therapies. They didn't use precise radiotherapy techniques, and they didn't use adequate pathological evaluation of surgical margins. So the idea of breast conservation started being reborn again. And many studies starting in the late 90s, like all this list, tried breast conserving surgery for multifocal, multicentric disease. And many of them reported very good local recurrence and overall survival rates when breast conservation was compared to mastectomy. So this added to the treatment options of multifocal, multicentric disease, a new entity, which is breast conservation in the form of either partial mastectomy, where a slice of the cake is removed, a slice that contains all the tumors, or another entity, which is multiple lumpectomies, where all the tumors, each and every tumor is removed separately with separate safety margin. And then many studies started appearing, and they tried to compare breast conservation with mastectomy for all types of breast cancer, whether unifocal, multifocal, or multicentric. And as you can see here, the disease-free survival is very close in both mastectomy and breast conservation. Another French study from the Institut Curie showed that whether mastectomy or a wide lumpectomy were done for multifocal breast cancer, both gave the same 5-year overall survival and the same 5-year ipsilateral breast recurrence rate. This led to the change in the St. Gallen expert consensus in 2017, where the panel in St. Gallen strongly endorsed breast conservation for both multifocal and multicentric disease on condition that surgical margins are negative, radiotherapy is used, and adequate cosmesis is achieved. Finally, this led to the appearance of a very important study, which is the American College of Surgeons Alliance Z1102 study, which is a prospective single-arm non-inferiority trial that tried to assess breast conservation in patients with multifocal and multicentric breast cancer. The primary endpoint of this study was to find the number of operations needed to successfully achieve negative margins and the rate of conversion to mastectomy. And the secondary endpoint was to evaluate the cosmetic appearance and local recurrence rates after breast conservation for multifocal and multicentric disease. This is the design of the study. Patients were all females over 40, BRCA negative, with no use of neoadjuvant systemic therapy and no previous radiation. All patients had 2 to 3 lesions, multifocal or multicentric, and tumor excision was done through either a single or multiple incisions, and negative margins accepted were no income tumor, and adjuvant radiation was given to the whole breast with a boost of 10 to 16 gray to each and every tumor bed, taking into consideration that less than 40% of the target breast tissue should receive over 60 gray. Now, the primary endpoints were achieved in this manner. The percentage of conversion to mastectomy was only 7%, and the number of operations required to achieve negative margins was only 1 operation in 73% of the patients and 2 operations in 23% of the patients. These numbers lie in the middle of the numbers that were previously reported for unifocal breast cancer. As you can see, this publication by Monica Moro states that her rate of re-excision and rate of conversion to mastectomy was 4%. In the American College of Surgeons, it was 7%. And in another study by Jennifer Wolge in 2008, the percentage of repeated excision was over 40%, and the percentage of women requiring mastectomy was 11%, which is more than the American College of Surgeons. So really, the results lie in the middle between the other results reported for unifocal breast cancer. Secondary endpoints of breast conserving surgery trial Z11102. Number one was the cosmetic result, which was found to be good to excellent in almost 70% of the patients, taking into consideration that these patients could have multiple incisions and multiple lumpectomies. And the local recurrence rate was found to be 3.1%, which is quite acceptable since it is less than the required 8% acceptable rate of local recurrence. These patients had lumpectomies. I'm reminding you, they had lumpectomy with negative margin with whole breast irradiation and a booster dose to all lumpectomy beds. So this led to a very important trial, which is the Miami Consort trial in the UK, which was supposed to be a prospective randomized controlled trial trying to compare breast conservation to mastectomy in multicentric breast cancer. It was supposed to be done in 25 UK breast units, and it started in June 2018. It started with 1,600 patients, and due to very thorough exclusion criteria and due to very weak patient compliance, they could only randomize 4 patients at the end. So this study really failed and it stopped. And this is the problem with randomized controlled trials trying to compare conservation to mastectomy in multicentric breast cancer. This leads me to talk about a very interesting new theory that is called lobar surgery for multicentric or multifocal breast cancer. This is based mainly on the sick lobe hypothesis that was introduced by Todd in 2005, which is mainly based on Sir Ashley Cooper presentation of the lobar anatomy of the breast. And it states that genetic mutation that leads to breast cancer starts during embryonic development and is transmitted in the distribution of the breast lobe. Accordingly, multifocal breast cancer is fundamentally lobar disease, while multicentric breast cancer is due to synchronous malignant transformation in 2 or more sick lobes. Here, the sick lobe is a lobe that contains the genetic mutation leading to breast cancer. And accordingly, this led to the new concept of lobar surgery for multicentric breast cancer, which means that in the case of multicentric breast cancer, if you excise 2 elliptical segments of breast tissue that have the configuration of the lobe, and these 2 elliptical segments are connected by a retroareolar bridge of tissue, this can lead to effective excision of multicentric breast cancer with very good satisfactory cosmetic outcome and breast preservation. So this is the summary of the development of the idea of breast conservation for multicentric breast cancer, which started in 1840 with the Ashley Cooper theory of lobar anatomy of the breast, and which ended by the application of the sick lobe hypothesis concept for lobar resection in multicentric breast cancer. And my conclusion are the following: that multiple lumpectomy is a promising therapeutic option, but nevertheless, it is not in the guidelines yet. That's because we still need prospective randomized control trials, including adequate number of patients. And this is not very easy to achieve. And to do that, we have to take into consideration that oncologic safety is our first priority, that radiotherapy boost should be given to each and every tumor bed. We have to take into consideration the tissue tolerability to radiotherapy, final cosmetic results, and acceptable local recurrence rates. Thank you very much.
Thank you, Professor Sharif Naguib, for this very interesting talk. And we postpone questions to the end of the session, please.
And now I'm going to introduce my dear professor, Professor Dr. Saad Isa, Professor of Pathology at the National Cancer Institute, our dear institute. And his talk will be about the practical application of immunohistochemistry in breast cancer.
Thank you, Professor Magda, for the introduction. I would like to acknowledge and thanks for the organizing committee, and especially Dr. Rada from the National Cancer Institute. Today, I will not mention many new things, but I will stress some important things which are, that's why I'm calling it as practical application. The classification of breast cancer, routine histology, immunohistochemistry, and the molecular signature. As regards the classic histologic types of breast cancer, as we know, the predominance is ductal carcinoma and other subtypes. The diagnostic markers which we should use in any routine pathological lab. It's EK adherence, P63, HLA, ER, and estrogen receptor. The EK adherence is a transmembrane glycan, which is calcium-dependent adhesion molecules. Its function is to adhere the cells together, and this will be translated as a shape for the cells. We have the columnar cells, we have the cuboidal, we have the acini and ducts. We use the EK-adherent monoclonal antibody to differentiate between ductal carcinoma and lobular carcinoma. Sometimes some of these cases are difficult, and some people will take the easy way to call it mixed types. So if you want to be perfect in the writing the type of this cancer, we should use EK adherence. We have ductal carcinoma. They have a positive staining for EK adherence, while lobular carcinoma is not. And this may explain the behavior difference between the ductal and the lobular carcinoma. This is an example of ductal carcinoma, DNH and E, and then EK adherence, you don't see any of these cells show adhesion molecules on its cells. Here is a metastatic cancer of a ductal carcinoma with EK adherence. The important thing here is we notice that the normal cells, they contain EK adherence on the basement membrane and on the sides. And this makes the cells of the tumor to take the shape of a duct or tubules or a solid type. But here, with the cancer, they produce EK adherence all over the cells. And this helps the cells when they are metastasizing to be, against this trauma and the immunity of the patient, because they stick by using this EK adherence all over its. The ductal versus lobular carcinoma, why we differentiate the invasive ductal carcinoma, there is no much difference in the biological behavior between the lobular and the invasive.
and the ductal carcinoma, while in the inside we have different subtypes and they have different biologic behaviors. The human P63 protein, it is a member of the P53 family. A transcription factor is marked in the basal and the myoepithelial cells. And this is very important in two types of cancer, in the breast and in the prostate. In some setting, there is a difficulty to diagnose tubular carcinoma differentiated from the sclerosing adenosis, which is benign. In sclerosing adenosis, you will have the basal layers are highlighted by P63, while in the tubular carcinoma, here an example where the cells, they maintain the myoepithelial double layering highlighted by the P63 marker. I remind you, these markers are easily done on a parent sections. And this gives us a very important advantage of having any retrospective study. This is an example of in situ carcinoma and the invasive component. And you may notice that here the basal layers in the in situ carcinoma, they are present, despite the fact that there is fenestration, which is common in carcinoma, while the invasive carcinoma does not show any of this stain. Human estrogen receptor alpha and beta. There is difference between both of them in different tissues, different affinity for ligand, and different gene activation. The important here is that with immunohistochemistry for detection of the estrogen receptor, we have a very good and highly sensitive with specific ID5 monoclonal antibody, which is used now everywhere. And this, the staining of the nuclear stain for the estrogen receptor appear to be highlighted by this monoclonal antibody. And if you notice, you can see that the malignant cells, they have higher content of estrogen receptor than the non-neoplastic cells, which are in the built-in control. And the pattern of the positivity for estrogen receptor with this monoclonal antibody is more than 90%. The problem here with the estrogen receptor is that it's related to the fixation, because estrogen receptors are thermodivide. And with the hot temperature, even at room temperature, at the operation room, you may lose, if you do your biopsy until it goes to the pathology lab, you will lose like 50% of your estrogen receptor. So fixation is fundamental. And if you don't guarantee a good fixation, immediate fixation, you don't look for the score which you get from the pathology lab about the percent of the positive estrogen receptor. The pharmacogenetics and pharmacodiagnostic. Pharmacogenetics are a new type of research and science which recently introduced into the medical literature nowadays. What is the pharmacogenetics? It's the study of genetically controlled variation in the drug response by each person. It's based on two genetic variations. What is called microsatellite variability and the single nucleotide polymorphism, what we call SNP. And there is variation in the gene copy number for each individual. And the SNP is encoding and non-coding gene parts of the genes. If you look here, you find the structure of DNA. We have in the base AT or G. If you have any change of a single nucleotide, then you get this step. So the SNP is a single base pair difference in the DNA sequence. They are responsible for the unique characteristic of every individual, from the hair color to disease predisposition. And here is the thinking provide a change in only one base of DNA will make the difference. And the end result of these two variables when it makes that the behavior of each of us to the given drugs will be very variable. And we can use this for study predisposition of the disease like diabetes or rheumatoid or whatever, and the response to the therapy. This is the microsatellite. So the driving force for the pharmacogenetics, which is the drug development based on the knowledge of the human genome, is the development of what we call pharmacodiagnostics, which are the tests which you do by pathology using this immunohistochemistry. So if you have one drug activated by enzymes, and then metabolized to be an active metabolite. So we have three types of response. Hyper-metabolizer, which is no effect, or normal metabolizer, or a poor metabolizer. So, for example, if we take tamoxifen, the inactive drug activated by enzymes to give an active metabolite. So we have normal metabolizer, which give the desired effect, or a poor metabolizer, which give no effect. The enzyme here is cytochrome, what we call D26, and we find that the report coming from pathology lab that this case of cancer is strongly positive for receptor, but not responding to tamoxifen. So what is the underlying cause of this difference? Why this patient is not responding to the treatment? We discovered that the D26, they have at least three, not only three, but many subtypes. And we have to restore the genotype to normal. So we have three modalities. One of them is the 2D6, 3, 4, 5, 6, which lead to the production of enzyme which is not functioning, or it is reduced effect, or no effect at all. So one of the when you get a patient with no response, but despite the pathology report will give you a very nice hormonal response by pathology. So you may guess why it is not responding. And then we go to the new era, which is expression profile DNA microarray. Since 206 appear in Scandinavian country. The report of sort it had about there are the breast cancer is not one type, at least we have some type of cancer. And this by expression profiling. You have luminal A, luminal B, and the breast right and ER and HER2 positive. Beforehand, as a pathology, we know that the breast, the normal breast SNI, they have a basal cells and secretory cells. By electron microscopy, the luminal cells have a microvilli on the surface and the desmosomes. And this will be translated by immunohistochemistry into a molecular profile. We have distinct subtypes. These subtypes has histologic and immunohistochemical features. They have important clinical implication. So we have used this as a surrogate, as indirect proof for the molecular classification of breast cancer. The molecular classification of breast cancer, it needs DNA microarray. but we use in the immunohistochemistry indirect proofs. So we classified the types of breast cancer in the estrogen receptor positive, what's called the luminal A, estrogen receptor and HER2, what is called the luminal B. Only HER2 positive, we call it HER2 subtype, and the basal marker, what is called the basal-like subtype. The triple negative breast cancer is that the basal-like phenotype, the metaplastic carcinoma, the medullary and the salivary-like, ductal carcinoma, and the uncalcified. The metaplastic carcinoma, what is called the basal-like carcinoma, they are positive for P63, high molecular weight cytokeratin CK5-6, and positive for EGRF, adherence, as well as CKIT and S100, while the medullary carcinoma, they have a specific marker, what's called HLA-D. These are some examples of the metaplastic carcinoma, what we call the spindle cell, and sometimes we have a report about sarcoma, which is not really one. And here the cytokeratin positive and the P63 positive spindle cells. Here you have excessive necrosis and high-grade tumor with positive staining for high molecular weight cytokeratin. The metaplastic carcinoma immunohistochemical marker, the squamous matrix forming spindle cell carcinoma sarcoma, the CK broad spectrum, and P63 and high molecular weight CK5/6, and the thermal growth factor receptor. This is an example of what we call squamous cell carcinoma. It's not really squamous, but it is the metaplastic breast carcinoma. The triple negative breast cancer, other types, salivary type, and apocrine and metastatic carcinoma. Apocrine carcinoma, the immunohistochemical marker is androgen receptor and the cross cyst disease free protein 15. They are a specific marker for highlighting this type of cancer. And if we go to another parameter, which we based our classification for, the proliferation marker, we have different proliferation marker, but the one which stands the time is the Ki67. The Ki67 is a protein which evolved during the cell cycle in cyclic cells, but not resting cells. So if you have the cell cycle, it will be highlighted only those cells in the cycle, and excluding the non-cyclic cells. One of the tissue which sometime in the beginning we used as a positive control is a tonsil. Here the surface epithelial base of the squamous cells, the basal cell layer, and highlight the germinal cell. And the cutoff value was 14%, and now it is raised to 20%. About the HER2 testing, we have three methodologies to identify the HER2 new immunohistochemistry, which identify the protein overexpression on the surface, fluorescent and cyto hybridization phase stage. It is important to identify and counting the gene amplification and the gene copy number and the serum for biochemistry. In the old days, we used only single color fish, but now we use double, which include a probe for the HER2 gene and the chromosome 17. The chest it is much more difficult, but it can be used by ordinary microscope. While the fish it needs fluorescent microscopy, and we use two probes to highlight chromosome as well as the gene. And here an example of such with amplification of the copy numbers indirectly seen by the black or brownish color in the nuclear tumor cells. Now we shift to the immunology, and now we started to use as a routine the PD1 and the PDL1 markers. And as you know, the PD1 is gene located on chromosome number 2. It is known to cell checkpoints expressed and used by a variety of activated immune cells, while its legend is called LD1, and we have a good monoclonal antibody which highlight and make us to identify the tumor cells from the structure. Here some example of the expression of the tumor. All this methodology we used as pathology, it shrink the number of the patient for pharmaco treatment or treatment after pharmacodiagnostics. For example, if we wanted to know how many patients are eligible our role as a pathologist is to validate the huge number of the monoclonal antibodies allocated to in the market. So I also urge our colleagues and the students to be involved with not only in HLD examination of pathology, but also in this validation of this monoclonal. Thank you.
Thank you, Dr. Saad, for such a fruitful lecture. And any questions? Questions at the end of the session. And now the next speaker.
First of all, I want to thank Dr. Amani Hilal and the Baheya Foundation. They invite me to chair them their sixth conference. And it's a great pleasure to introduce Dr. Amr Farouk, lecturer of radio diagnosis and intervention radiology NCI and the consultant in Baheya Foundation, who will tell us about deep learning based cancer detection, a model for contrast enhanced mammography.
This is a combined lecture, AI-based contrast enhanced mammography. It will be presented by myself, and Lawrence Banker. The continuous advancement of AI in the field of breast imaging were intended to enhance the workflow in breast imaging units, decreasing the number of false positive and false negative results, upgrading the diagnostic performance of breast imaging radiologists, enrich the impact of breast imaging radiologists on patient care. AI-based solutions in the breast imaging have already been studied and adopted. Several successful AI technologies have been introduced in 2D mammogram, mainly in the lesion detection rather than interpretation. There is little in the literature exploring the potential impact of adding AI models to contrast mammogram. We have two mainly clinical applications for AI in contrast mammogram. The first is a diagnostic tool that classifies enhancing lesions in contrast mammography and produce corresponding score for suspicion of malignancy. The second application is contrast-based AI quantitative tool to assess the response of malignant breast masses to neoadjuvant chemotherapy. For the first, the AI breast cancer detection, there were multiple studies over the last years exploring the added value of contrast mammo in the initial evaluation of breast cancer and the planning of surgeries dependent on the accurate and objective evaluation of extent, multifocality, and multicentricity. Unfortunately, we still face difficulties in assessment. For this example, the best right breast masses, and the left breast, there is pathological non-mass enhancement. So the question, if the right breast mass is multifocal, and if the left breast non-mass enhancement significant. So here the AI that's developed showing suspicion score for the 3 masses in the right breast with score ranging from 41 to 80 and 23 with the areas measured in millimeters, while not marking the left breast non-mass enhancement. The patient had surgery from the right side, revealing upper outer quadrant multifocal invasive duct carcinoma, and on the left had wide local excision showing proliferative fibrocystic disease, matching the findings detected in the AI. This is another case with bilateral malignant breast masses, bilateral pathological proven invasive lobular carcinoma. And here comes the question, single, multiple, multifocal, multicentric, especially in the dense background, parenchymal enhancement and intense uptake. So the patient had the AI, which is developed from our side and GE, showing suspicion score for the right side and being detected as single mass in the right, and in the right MLO as multiple masses within the right upper outer quadrant, while the left showed only the one mass, neglecting and omitting the other enhancing nodules. The patient had right breast upper outer quadrant multifocal invasive lobular carcinoma, and on the left it was a single invasive lobular carcinoma as confirmed by the AI. AI-based neoadjuvant chemotherapy response assessment. The candidates for neoadjuvant chemotherapy include locally advanced disease, T2 tumors, and HER2 and triple-negative cancer. So why do assess the response to neoadjuvant chemotherapy? To evaluate pathological complete response, and the complete course of neoadjuvant usually in 10 months of administration of different chemotherapy drugs. The early prediction of tumor response is vital for the oncologist to decide whether to stop further unnecessary drug administration or change the line of management in non-responder. Radiologists play a fundamental role to supply the oncologist with the data regarding non-responder, partial, and complete responders, changing the line of management and knowing the patient prognosis. Surgeons have the data from radiologists regarding the relation to the skin, nipple, and chest wall, lesion multiplicity, and the size of the residual disease, allowing surgeons to plan for surgery and to decide to do conservative and mastectomy. We had several imaging modalities to evaluate the response, including mammography, contrast mammogram, MRI, and PET mammogram. And despite MRI being the modality of choice of evaluation, contrast has proved efficiency for evaluation of response to neoadjuvant chemotherapy. Unfortunately, with the best imaging modalities, we still face difficulties in assessment. For this case, there is pre-neoadjuvant and post-neoadjuvant images, in which in the post-neoadjuvant images, there is residual faint non-mass enhancement. So the question here, is this complete response or partial response? It's another case in the pre-neoadjuvant and the post-neoadjuvant chemotherapy showing the same area of extension with less evident, less intense enhancement. So the question, is she a responder or a non-responder being occupying the same area? This is another case with the pre and post-neoadjuvant chemotherapies showing decrease in the initial mass detected, the non-mass enhancement and the enhancing nodule in the upper outer quadrant, however, with a newly appreciated nodule. So the question, is it partial response since the mass and the decrease, or it's progressive disease due to the newly developed enhancing nodule? So can we overcome these difficulties by using the AI tools? Deep learning tools can extract quantitative and qualitative parameters from medical imaging beyond what can be perceived by the human eye. We had a long-term collaboration between GE and Baheya Hospital to propagate contrast-enhanced based intelligence quantitative tool to assess response of malignant breast masses to neoadjuvant chemotherapy. So this is an example of a breast cancer patient having a large breast mass in the right breast. The patient had, after the neoadjuvant, the images in the post-neoadjuvant showing progressive disease. This is the example of the AI solution in which the lesion is marked and changed into a color map showing its progressive disease with a percentage of progression about 240%. This is another case of the breast cancer having a mass lesion and anteriorly related pathological non-mass enhancement. The patient in post-neoadjuvant chemotherapy had complete resolution radiologically, which was confirmed by the AI delineating the area of concern, showing no enhancing lesions or viability. Now I'll present Lawrence Vankerberg. She is the chief of the research team in GE Healthcare.
Thanks a lot, Dr. Hamar, for this introduction and explanation around the clinical context. And thanks for inviting me to present our collaboration between Baheya Hospital and GE Healthcare about this AI tools. As you mentioned, we believe that contrast-enhanced mammography is a promising technique that will be increasingly adopted for screening of moderate-risk women, diagnostic, or even for therapy monitoring. This is why we started to work together on AI tools for this modality. I'm going to present two AI pipelines that we built, and the first one being around AI-based cancer detection. So on this slide, you can find the overall AI pipeline for what we call the CEM CAD. So basically, the goal is to detect cancer. So what it takes as input is the low energy image, which is like a standard mammography, and the recombined image. Then it goes through a classic convolutional neural network and gives us output, a box with a suspicion score. And it is done mainly to highlight enhancing cancer in the recombined image. Of course, to train AI, we need lots of data and we need ground truth. So as ground truth, we have all cancers was biopsy-proven cancer, and the annotation have been done by a radiologist that had access to all the patient data, so pathology report and all images of all exam. This is how the box were placed for the ground truth. Once you have those boxes, what you can do is look at the whole exam and all images of the same breast, and then you basically take the maximum score, and then it gives you a score for the breast. And you have what we call breast classifier. We use the same data for this, so it's also biopsy-proven cancer. One word about our dataset. It comes from different GE systems of all the world, but as you can see with the large purple bullets, our dataset come mainly from Baheya Hospital, and thank you for that. We have approximately 1,500 patient exam. You can tell me for AI, it's not that much, but it's the largest CM database in the world. To evaluate our algorithm, we use a dedicated dataset of 150 patients. What we can say about this dataset is that there are half cases with cancer. If we took it at the breast level, it means 1/4, because the contralateral breast is often normal. And to have a fair assessment of our AI tool, what we did is that we balanced it in terms of BIHATS. So there is approximately the same number of BIHATS 2, BIHAT 3, BIHAT 4, and BIHAT 5 lesions, just to have a non-biased evaluation. So here is an example of what our CAD do. So on the right breast, you have a cancer marked by a red box. And on the left breast, you have benign lesions that have been annotated and that have been biopsied benign. So you can see that our CAD in blue is detecting something on the right breast with a score of 0.7 approximately, and detects nothing on the other breast, on the benign biopsy. So of course, it's a case that worked well for the CAD. To do a fair assessment, so we assess the standalone performance of our CAD. So here on the left, you have what we call the fog curve, which means we look at the box level, what are the performance of our CAD. On the y-axis, you have sensitivity, meaning does our CAD detect truly the cancer? And on the y-axis, you have the false positive rate per image, meaning does the CAD put boxes where there is no cancer? If we look at these curves, the first things we can say is that if we took both images, low energy image and recombined image, it gives us better results than the recombined image only. So this low energy image helps the AI pipeline to have better performance. The second thing we can say is that if we are at a new power pinpoint of 0.9 in terms of sensitivity, we have approximately one false positive every 10 images. So the CAD will put a box that is not a cancer every 10 images, which for a prototype is not that bad. In terms of the ROC curve, so at breast classification level, the gray bullets are papers that you can find in the literature, and the size of the bullet represents the number of patients for this study. And its performance of radiologists for CEM. And what we can say is that our CAD, if you use it as standalone, it has an average performance that we can find in the literature, same as a middle range radiologist, I would say. But of course, the CAD is never used alone. It's used in a clinical setting, in a clinical environment. This is why the last couple of months, we conducted with Baheya Hospital a clinical evaluation of our CAD. 5 radiologists of Baheya Hospital did 2 phases of annotations. The first phase was without the CAD. So the protocol was to put a box and put a suspicion score on everything that they assumed are a concern. Then we had a break to do a memory reset and to stop to forget the cases. And then they did the same review of the same patient, but this time with the CAD. And this is also done to, we measured also for one of them the time to understand if there is influence in terms of workflow. This is one example quickly. So we see that on the right breast, there is a cancer well detected before and after the CAD. And on the left breast, there was a benign venopside ground truth that was annotated by 3 radiologists before the CAD. And with the CAD, there is less marked, meaning that we reduce the number of false positives for this case. Another example is the influence in terms of placement of the box and the number of boxes used when we apply the CAD. So here in white, you have the annotation without the CAD, and in yellow, the annotation of the radiologist with the CAD. What we see clearly is that the CAD displayed in blue, influences the placements of those boxes and the evaluation of the CAD extent. So this is the preliminary results. So you have the flow curve by radiologists. In green, it's where the CAD increased performances, in red, not. So we see that basically it improved the performance for all radiologists except one. And what we can say is that we see the opportunity to reduce the number of biopsy and to avoid one biopsy by every 14 patients. And the reading time was decreased by 30% for the one that we measured. Again, it's preliminary results and we want to publish them soon. For the second pipeline is dedicated to neoadjuvant chemotherapy response assessment. Here is the pipeline. So it takes as input the pre-NAC and the post-NAC images. Then we have a registration brick that's mapped the pre-image with the post-image, because of course it had been acquired in different breast position. And then we use the brick that was previously mentioned to detect automatically the lesions, and we feed that to an AI or machine learning tool. And what we predict as an output is 3 classes: complete response, partial response, and others. For the machine learning tool, we use not only the images, but also clinical information available. So why we need to finally map those pre and post-NAC images? If we directly subtract them, we see there is no clinical impacted image. We see the breast frontier, we see maybe a clip, but it means nothing because of course the images have been acquired at different positions. So this is why we apply registration. You tell me registration is something that exists for a long time, and you're right. But for the post-NAC image, what is noticeable is that sometimes the lesion disappear, or there is a big texture change between both exams. So the classic registration methods doesn't work well. And this is why we developed together a new registration method that is robust for NAC images. So basically what we do is while we are looking for motion between both images, we authorize the pixel value intensity to change so we can apply it to this NAC image where the lesion and the lesion area change a lot between both exams. We published this work also in a scientific paper. So this is how it looks like. On the left, you have the 2 images before registration acquire a different position, and the 2 images after registration, you see it doesn't move anymore. We check the performance of our method using landmarks. So we use vessel, clip, nipple, and we check that after registration, nothing moves. So then you can understand that now we are able to map those pre and post-NAC images perfectly. And when we subtract them, so you can see the results on the bottom right of the slide, you see that the blue area is appearing, and it was a progressive disease. So does it help to do this step? What we did another study where we compare to give to a machine learning algorithm the 4 images pre and post-NAC without registration. And we did the same thing while giving him this subtracted image. And what we can observe on the right is that you have the what we call the linear discriminant analysis, but basically, if the clauses are separate or spread, it's easier for the AI. And what we see is that with the registration, the yellow, the green, and the red cloud are more separated, meaning it will be easier for the AI to separate complete, partial, and insensitive classes. And it's also confirmed by the rock area, the area under the curve of the rock. So registration helps. And that's the end of my talk, and thank you for the attention.
Thank you. Very interesting topic. Now I have the honor and pleasure to introduce Professor Ahmed Amin, Head of Radiotherapy Department in Baheya Foundation. Will present a very important topic related to the role of stereotactic body radiotherapy for spinal oligomets. The floor is yours.
Good morning, everybody. Good morning, chairpersons. It's a great pleasure to be presenting here today, and I'm honored to have all this attendance in our 6th conference. For today's topic, I choose some interesting topic, which is addressing the stereotactic body radiotherapy for spinal oligometastasis. I'm sure all of us are facing such scenarios in our practice. The role of radiotherapy in general is totally established for breast cancer, whether it's post-operative radiotherapy or as a palliative radiotherapy. But for such scenarios, when you're facing such patient or treating such patient, when they're presented with just single bony metastasis or oligo bony metastasis, for such patients, when they are asking us as a physicians, am I terminal stage? Am I having metastatic disease? I'm exactly the same as all the other patients who are having disseminated metastasis. During the last few years, we had the definition of oligometastatic disease. I didn't insert any slide with proper definitions, since this definition is changing almost every 1 or 2 years, because we still don't define exactly the oligometastasis, but we're working on this. And this is a very interesting area for research, because definitely such patients are not and should not be treated like patients with disseminated disease. We're having data from MD Anderson that they, for this, that they documented that the patients for whom we were able to treat the disease radically, so that there is no evidence of disease, those patients, they have a much better survival. We also had, from a couple of years ago, we had some important trial, the SAP or COMET trial. It's a phase 2 randomized trial that they randomized SBRT versus control arm, and they documented survival benefits of SBRT for oligometastatic spinal disease. So, but before considering SBRT, we have to make sure that we're having the facilities and the experience that should allow us to perform such advanced treatment, as advanced machines and proper patient selection and proper target evaluation and organ at risk proximity and enough experience. And remember, all of the SBRT should be done within clinical trial contexts. In general, when we are considering SBRT, we prefer a patient with favorable biology, younger age, good performance, asymptomatic patients, long expected disease survival, lower tumor burden, as we mentioned, and limited number of involved organs. As I mentioned, it's also preferred to get biopsy from this oligo. Since it's just one lesion, we have to make sure this lesion, for example, is not a traumatic lesion or some other disease rather than malignancy. So before considering this or defining this lesion as a metastatic lesion, we have to consider a biopsy, and we have to consider treating the primary before treating this oligometastatic disease. And there are ongoing trials for patients, breast cancer patients with oligometastatic disease, that we should consider treating them radically and performing surgery, radical breast surgery, then to treat the secondaries, but primary should also be treated. We're doing a lot of SBRT these days because nowadays we're having better early diagnosis, improved diagnostic tools, improved systemic treatment, advanced radiotherapy machines, and we're having better experience. And as I mentioned, this is a very interesting area for research. The indication of SBRT, we can classify them as de novo SBRT, salvage SBRT for those patients who already received radiotherapy before, and post-operative SBRT, still SBRT after decompression of the spines. SBRT still to be considered, and decompressive SBRT, we can call it as some sort of palliative SBRT. In general, for those patients, they have to be properly diagnosed and well staged, and the most important investigations to be requested in the spine and MRI. And biopsy, as I mentioned, if we are not 100% sure of the disease, it's better to have a biopsy from the lesion before starting treatment. The Astro provided us with very useful inclusion-exclusion patient selection criteria before considering SBRT. And for a patient who is candidate for SBRT, we should perform what's called, it's better to perform what's called the spinal spinal instability neoplastic score. Spinal instability neoplastic score, it's a score depending upon the location of the lesion if it's painful or not, and the degree of pain, the bony lesion type, whether it's lytic or sclerotic or mixed, its appearance and the imaging, and if there is any collapse, and of course, if there is protrusion or intraspinal disease. We're getting score, and according to this score, we can classify the patient if they're gonna benefit from the treatment or not. There is also what's called the Pilski grade. The Pilski grading depend upon the lesions who are having some extra spinal disease or components. According to this degree of bulging of the tumor of the soft tissue, we can classify them whether they are candidate for SPRT or if the SPRT should not be considered for them. And of course, the patient should have a good life expectancy and good performance. The exclusion criteria for SPRT, it's depending if the patient have the previous SPRT, if the patient had palliative radiotherapy within 90 days, if having a worsening neurological symptoms, inability to lie flat, less than 3 months expectant survival, and spinal canal compromised more than 25%, or inability to have MRI, or if he's under chemotherapy, we shouldn't consider SPRT during chemotherapy. And remember, SPRT, as I mentioned, it's very technical treatment. So if during any part of the treatment you felt that you're not confident of delivering a safe treatment, you might change your mind and like take a back step. Some technicality for the simulation, we have to, as I mentioned, the whole process should be very precise. We have to have proper embolization using the backlog, obtain a very thin slices to be able to identify the lesion properly. The patient should be extremely fixed because this treatment is very, very critical because we are treating the patient who are very proximal to the spinal cord. Sometimes we're having less than 1 millimeter gap between the lesion and the spinal cord, so the treatment should be precise and safe. I'm not going to go through some technical aspects like delineation, but in general, when we are treating, we are not treating just the lesion, we are treating the lesion and mostly the body of the vertebrae, the whole body is treated to be able to make sure that the whole disease in the vertebral body is going to be treated. The prescribed doses, it could be delivered over 1 fraction, 2 fractions, 3 fractions, 5 fractions, depends upon the experience. So whenever the center having more advanced machines and more experience, less number of fractions can be delivered. And beside the experience, the nature of the lesion. So lesions with extra spinal component, a larger number of fractions should be considered. The constraints should be respected, and there are constraints for every number of fractions. Whenever the protocol which we're using, we're gonna choose the proper constraints to follow. As I mentioned, some patients already, they received palliative radiotherapy to the same site before considering SPRT. So for those patients, such patients, we have different constraints. For example, the spinal cord, when we are treating on, if the patient received 20 grays over 5 fractions or 30 grays over 10 fractions, we are considering just 9 grays to the spinal cord. And if we're treating in 3 fractions, 14.5 instead of 12.5. So it's like we're having a more strict constraints. And this is an area of research. We're having many publications these days on the tolerance of the spinal cords, since we are doing more SPRT these days. Expected toxicities, acute toxicities in the form of dermatitis, esophagitis, nausea and vomiting, pain, flare, and fatigue. And for late toxicities, skin coloration, vertebral compression, which is the most serious complication, radiation myelopathy and radiation plexopathy, and esophageal tract stenosis. This is like one of the cases who were treated and have some collapse after 6 months of treatment. Local control, we're achieving an excellent local control with SPRT. The local control reached up to from 80 to 95%. So this is a very, very satisfying values. We in general, serious side effects, we're not having them only in 5%, which you can notice. pain flare, without adding steroids, patients might complain of pain. 68% might complain of pain. So with steroids, this number goes down to 19%. So adding steroids with the treatment is extremely mandatory. Myelopathy is rare to find myelopathy, and vertebral fracture, it's more common with single fraction, reach up to 39% with the single fraction. So vertebroplasty or cement, vertebral cement insertion, it's advised when we're using single fraction. Of course, we might get some bowel toxicity with SPRT. So it's important to have very proper plan. So that's if the center is not experienced in SPRT and not advising to perform this advanced technique without having enough experience. If we're having like this image, the esophagus, it's very near from the vertebral or the PTV. We have to exclude this organ at risk before considering our targets. For some special consideration, like for example, it's a head and neck, it's a cervical vertebrae case. We have to contour the posterior pharyngeal wall. We're adding like extra organ at risk to be able to deliver the treatment safely. Of course, as I mentioned, good plans should be available before considering the treatment. This is example for a plan which is not a perfect plan. There's something what's called street phenomena, as we're leaving, having a lot of segments. So you might find part of the dose outside the target. So the acceptance of the plan should be performed very, we should take our time and we should do it and take our time in this acceptance. In just a couple of slides, I'm gonna give you our experience in SPRT. We're having so far 5 years of experience. We treated up to 42 oligometastatic patients. This was updated on August, actually. The local control, so far we're achieving 85% local control. We had only 5 patients who progressed during the last follow-up. We still don't have the progression-free survival data. We're planning to actually collect these data and publish it soon, hopefully. And actually, beside that, we're doing a lot of other SPRTs for other cases rather than breast cases, but they're not included in this numbers. Most of our cases, actually, they having the oligometastatic disease in dorset and lumbar vertebrae. Alhamdulillah, we don't have any significant toxicities. So far, we are confident of our treatment. But the protocol which we're using is the 3 fractions protocol. We're not actually prescribing a 1 fraction. So the risk of complication with this protocol, as I mentioned, is lower. That's why we're not having any serious complications. This is one of our cases. It should be properly contoured and the plan should be performed very precisely, and all the idodoses should be evaluated. Another case where we prescribed 27 grams of 3 fractions, and this is the standard dose which we're using. This is another case which was treated. The initial PET-CT was, the maximum SUV was 14.6. After 3 months of treatment, it became 2.6, and the last follow-up, we didn't have any uptake in PET-CT. So my take-home message is SPRT is a promising therapy for patient with spinal metastasis. Its role is still under investigation, but most of the published data are supporting its potential survival benefits. To conduct such advanced technique, certain levels of experience and technology must be available to ensure its safety and efficiency. Thank you very much.
Thank you, Dr. Ahmed. Thank you for sticking to the time, and we appreciate that. We will end our session by my colleague, Professor Maher Hassan. He will be taking us in a different aspects of management that will be extended thromboprophylaxis after abdominopelvic cancer surgery. ما اعرفش ايه علاقه ده بالبريست، بس ما فيش مشكله يعني. هنسالك برضو، هل اسالك سؤال بس في الاول، انت هل في البريست سيرجري patients who needs DVT prophylaxis في البريست.
Yes. Actually, the cancer-associated thrombosis is all cancer patients, and I will present in the presentation a slide about the top 5 cancer sites correlated with the DVT, and you will see it. Thank you دايما في حضرتك في challenge. First of all, thank you very much, Dr. Hamdi. Thank you, Mr. Chairman. I'm Hassan. I'm Associate Professor at National Cancer Institute and the Head of Breast Surgery Department of Baheya Foundation. And it's my honor to be with you today, and we'll take you to not that far away other topic in our conference, but it's a very important related item to our daily work. We encounter this in our daily work. It is the cancer-associated thrombosis, the best of guidelines, or the CAT. Actually, CAT was first described in 1865. It's not not a new concept by Armand Rossi as a migratory superficial thrombolysis. Then Berkow studied the pathophysiology of the venous thromboembolism and its relation to the cancer at all, not only the pelvic cancer or any cancer, but the cancer at all, which is the endothelial injury by the tumor invasion from all cancer types, cytokines, chemotherapy, venous catheters like central lines or the portacas. Also, the hypercoagulative state due to the cancer-associated cytokines, and the immobilization of all cancer patients and the tumor compression by the heavy burden tumor and the changes in the blood viscosity. Actually, tomorrow is the birthday of Rudolf Virchow, and the International Society of Thrombosis named the day the World Thrombosis Day. So why should we care? Why should we care about the cancer-associated thrombosis? Is it a problem? Yes. It's one of the most leading cause of death in all cancer patients. And as we see, it is the second common cause of death in all cancer patients after cancer itself. As we see, cancer progression is related to 71% of the cause of death, and the venous thromboembolism is 9%, and the other causes not related to the cancer is this, and so it is the second leading cause of death by the guidelines. What's called occult cancer in unprovoked venous thrombosis? Actually, unprovoked without any cause venous thrombosis may be the earliest sign of cancer. Up to 10% of patients will be diagnosed with cancer in the year later on. So occult cancer screening in patients with venous thromboembolism is not that mandatory, but should be undergo a limited cancer screening with unprovoked thromboembolism without any cause. As I see to Dr. Hamdi, this guidelines showed the top 5 most common sites of cancer associated with the venous thromboembolism, and in men, the lung cancer, and women, the breast cancer, due to the high number of breast cancer patients and overall in the breast cancer patients. So we should tackle this item before it occurs. The prophylaxis in the venous thromboembolism is the mainstay of treatment. Actually, the preventive measures like the compression stocking and anticoagulation therapy is the main 2 items: anticoagulant treatment and the usual daily lifestyle, and the compression stocking devices is another option. So, what is the rationale of the prophylaxis in our cancer patients? Actually, diagnosis of DVT and pulmonary embolism are often more difficult, and the treatment of the DVT in cancer patients is very challenging. As we see during the hospitalization, there is a very high risk of developing cancer, developing pulmonary embolism, or developing venous thromboembolism. 4 to 6-fold increased risk of venous thromboembolism in patients related to cancer, especially during the hospitalization. And all through the journey of cancer treatment management, as we see, the incidence become high and low. It is only low in the remission stage, but during the whole stage, even during metastasis or during hospitalization or during active treatment, there is a very high risk of developing venous thromboembolism. So the prevention in cancer patients, the use of thromboprophylaxis in cancer patients can be considered in 3 settings: ambulatory cancer patients, outpatient patients receiving chemotherapy, like cancer patients admitted to hospital with acute illness, and cancer patients undergoing surgery. This is the mainstays to prevent the cancer, the venous thromboembolism. The cancer thrombosis risk assessment models we have many models to assess our patients, and we will show in the presentation the risk assessment models according to the guidelines. And in the NCCN guidelines 2030, the recent update, the Corona score for patient receiving chemotherapy is used for assessment of the risk of developing thromboembolism, depending on the site of the primary cancer with the scoring system. A very high risk patients in the stomach and the pancreas, and the other high risk patients in lung, lymphoma, and gynecological diseases. And the pre-chemotherapy patients with low platelet counts, also hemoglobin or high platelet count, hemoglobin level less than 10%, and many other factors. And one of the most important is the body mass index and the obesity, which is related to the breast cancer in a direct way. Another scoring system for the surgical patients is the Cabrini score, which develops many factors. Each risk factor represented with a points, either 1 point, 2 points, 3 points, to clearly define the patient at risk for cancer development. So the prophylaxis in ambulatory cancer patients receiving chemotherapy, primary prophylaxis in ambulatory cancer patients reduce the risk of venous thromboembolism effectively, with a reduction risk about 60%. We'll go directly to the thromboprophylaxis in cancer patient. All patients with a malignant disease undergo major surgical intervention should consider for a pharmacological thromboprophylaxis with either unfractionated heparin or low molecular weight heparin. And the prophylaxis should be commenced pre-operative. We should start the prophylaxis before the starting our surgery, as the ASCO guidelines elaborated. Actually, mechanical methods may be added to the pharmacological methods, and the combination of both treatment is important as per guidelines. So the pharmacological thromboprophylaxis should be continued at least for 7 to 10 days in all patients. And the extended thromboprophylaxis with low molecular weight heparin for up to 4 weeks post-operatively should be considered for the patient going a major abdominal or pelvic surgery. We should extend our thromboprophylactic measures for patients with high risk, patients for developing DVT, like patients with pelvic abdominal cancer undergoing major surgery, to 1 month post-operative. And we should start it 1 week pre-operative. As encountered in the NCCN guidelines 2030, the last version, consider pre-operative dosing with unfractionated heparin or low molecular weight heparin for high-risk patients in abdominal and pelvic surgery, plus or minus intermittent pneumatic compression. Again, we should extend according to the NCCN guidelines. Last version also, pure thromboprophylaxis for high-risk patients for up to 4 weeks. So as we see in the ASCO and the ESMO guidelines, they consider the thromboprophylaxis 1 week before surgery, and they extended to the high-risk patient after surgery for 1 month. We will shift to the treatment of the venous thromboembolism in cancer patients. It's very challenging. Actually, treatment is challenging because treatment complicated by chemotherapy, anticoagulant management during invasive diagnostic and treatment procedures, and individualization of the anticoagulant treatment duration based on clinical status, stage of the disease, and the risk of recurrence and the patient preference. So we should start with low molecular weight heparin as effective as unfractionated heparin for initial therapy in cancer patients, and the low molecular weight heparin was associated with a statistically significant reduction of mortality at 3 months follow-up compared to the unfractionated heparin. The advantage of low molecular weight heparin in over warfarin, the routine laboratory monitoring not needed, the weight adjustment dosing not needed, lack of interaction with diet, and the accommodate the invasive procedures that may be urgently needed for the patients. And in the same guidelines in 2030, also there is increased survival rates have been reported for subgroups of patients receiving chronic treatment with low molecular weight heparin versus other venous thromboembolytic therapy or placebo. Sorry. Again, at least 3 months, as long as active cancer therapy is present, is maybe the anticoagulant therapy in patients in the circumstances of treatment. You should extend at least 4 to 3 months as long as active cancer is present. So, as we see in the National Comprehensive Guidelines published in the Oncologist, in this paper published in the Oncologist 2021, low molecular weight heparin is preferred over the DOACs in patients with GIT malignancy. So this is a diagram that shows the treatments cancer patients with antithrombotic agents, patients with active cancer and acute venous thromboembolism. If the platelet count is less than 50, yes, low molecular weight heparin is the preferred option, but case by case with reduced dose or full dose following platelet transfusion. If the platelet count is higher, the molecular weight is 3 to 6 months. If there is complete remission, okay, and the low molecular weight heparin. If there is no complete remission and the ongoing cancer is still present as ongoing anti-cancer treatment is still present, continue the low molecular weight heparin. And if the disease becomes stable, you should consider continuation of low molecular weight heparin or shifting to the WACs according to the patient preference. The same in the this guidelines published in the Annals of Oncology. And finally, we conclude that all the guidelines, the ASCO guidelines, the SCA guidelines, and that we should start initial treatment for 5 to 10 days with low molecular weight heparin and extend the treatment to 3 to 6 months as extended treatment in patients with active DVT with active cancer patients. And in this case presentation will explain the presentation. In this case, 62 years old female patient with type 2 diabetes mellitus and the body mass index 28 and the family history of unprovoked DVT, admitted for colon cancer surgery treatment. So according to the score we presented before, if this patient is low or moderate or high risk, actually we'll go to the to our scoring system, we'll find that the patient is obese. Actually, the patient is old and with major surgery and have a malignancy and have family history of thrombosis. So the score is more than 5, so it's high risk patient. So we should start our risk is high risk patient. So we should start the treatment with. So as we see in the ASH guidelines, the low molecular weight heparin is or Fondaparinux over fractionated heparin is preferred. Also, we recommend the duration, no recommendation on the use of vitamin K antagonist or the WACs in this thromboprophylaxis. And according to the American Colleague of Chest Physicians, the high risk for DVT, for more Caprini score more than 5. Low molecular weight heparin is advised. So the treatment of the best option for treatment is the low molecular weight heparin. And for how long we should continue our treatment, again, according to the guidelines, we recommend extended duration of pharmacological thromboprophylaxis for 4 weeks, and another guidelines the same. Also the same in another guidelines. So the best to extend the treatment for 4 weeks. And we conclude finally that cancer-associated thrombosis is common and associated with poor outcome. The risk of thrombosis is variable by type, stage, treatment of cancer, and other risk factors. And the risk assessment models may help individualize the treatment for the patient. And low molecular weight heparin remains therapeutic option. Duration of the treatment depends on the status of the patient over the risk and other risk factors. And DOACs should be investigated more carefully before being used in cancer patients, especially patients with GIT malignancy and patients at risk of bleeding. And thank you.
Thank you, Dr. Maher. I'm just taking from what you said, for patients who require 3 to 6 months, there is an oral types of heparin and low molecular weight. I don't know.
Yes, oral anticoagulants.
Yes.
Maybe DOACs, the oral vitamin K antagonist. But as I mentioned, this in the usual patients, not in the high-risk patient with cancer, especially the GIT cancer patient, because the absorption of the DOACs from it's actually from the duodenum, and in gastric cancer and in the GIT malignancy, there is no control for the oral anticoagulant. So it is preferred to go for low molecular weight heparin, more controllable.
Very important topic. It can be applied everywhere in breast cancer and hidden neck cancer, many others. Any question, Dr. Maher, before he leaves the floor?
Dr. Maher, thank you so much. It's a very important daily life patient receiving Biva.
Receiving what?
Bevacizumab, Avastin.
We don't know actually the full applications of the.
Okay, Avastin. Okay, in our daily life, especially for those patients with cancer ovary. Okay, how to monitor your patient?
Actually, as I mentioned, it was mainly about the surgical patient, but the patient who is receiving active treatment for cancer with chemotherapy, we have a long presentation about that, but now it's not available with me. But we should prepare to go for low molecular weight heparin. This is very controlled for its duration of action. We can stop it easily and without high risk.
What about erythropoietin factor?
What?
Erythropoietin factor, like Brex, yeah.
No, I don't have a full view about this.
Some data addressing that using erythropoietin factor, increasing the incidence of VTE. Do you have any comment?
I maybe encountered, but I don't have full data about it.
I would like to ask our dear colleague, Dr. Heba, Dr. Amani, to contribute. And my question, while you're giving neoadjuvant chemotherapy prior to surgery, would you stratify patients who are liable to develop DVT and give them anti-DVT treatment or anticoagulant treatment prior to surgery?
Professor Dr. Maher, Hassan, thank you very much for invitation and for the presentation. It's great presentation. أستاذ الدكتور حمدي المراكبي، أستاذ الدكتور حمدي المراكبي، حضرتك بتسألنا على breast cancer patient if she is a high risk because of age or because of previous stroke or previous anything. We do the normal regular measure because, as you know, this is not a major surgery, but this is very important not to take any thromboembolic induced treatment like tamoxifen and like other new drugs that may increase hyperlipidemia and cholesterolemia and propose the patient to DVT. هقول example بالعربي. العيانة اللي أنا قررت هي عندها مثلا 65 أو 70 سنة وأنا قررت because of her biology I will give her hormonal treatment, endocrinal treatment. Take care. Endocrinal treatment, and this endocrinal treatment this endocrinal treatment may be tamoxifen or may be aromatase inhibitor. In both conditions, I have to revise very carefully her thrombo event history. This is very important. I will not include in her neoadjuvant any agent that predispose. لأن when we start with DVT, we have to يعني نقول لنفسنا هي مش DVT، هي ممكن تكون pulmonary embolism. يعني this is maybe a fatal condition. لو سمحت لي يا دكتور حمدي عايزه اعلق عشان انا كان عندي حاله واستشرت حد very expert في when the patient have bleeding tendency like in leukemia or I ready to give him bevacizumab and I know in advance that this patient may have bleeding. So we have to wait the importance of DVT versus bleeding. يعني قد يكون ال DVT long standing والبيشنت عندها كل الفاكتور either pancreatic tumor or gastric tumor وعمل عملية and bedridden، يبقى ده رايح يجي له pulmonary embolism. We have to give him something. مش هنخاف من البليدنج علشان يحصل له major effect. طب ازاي؟ مش هندي فيتامين كي اكتيفيتد فاكتور لانه we have to do INR باستمرار، ولازم ندي لو موليكولار ويت، ولو هو زهق من اللو موليكولار ويت والشكشكه هنروح على الحاجات الجديده والدواكس. وانا بقى في الحته دي بالذات I would like to call everybody حتى myself to involve vascular expert in the treatment of such patients.
دكتوره هبه يعني بشكر حضرتك جدا لان السلايد دي بتقول نفس الكلام بتاع حضرتك، متاكد ان هي تيلور لكل بيشنت. ان في الميديكال بيشنت receiving chemotherapy routine pharmacological prophylaxis is not recommended in all cancer patients, but based on the randomized clinical trial and the limited data, clinicians may consider a low molecular weight hemorrhage prophylaxis on a case-by-case basis in highly selected outpatient with solid tumors receiving chemotherapy, and also is focused on the patient with multiple myeloma receiving thalidomide or receiving darinadomide based regimens. So it's the same as you mentioned. Thank you.
Thank you, Dr. Maher. Any question to all the speakers? If you remember any. سعيد.
سؤال صغير كده يا دكتور شريف بيه نجيب، هو هيعمل مالتيبل لامبكتوميز، هيعمل في الحالات دي اكزيلاري كليرنس ولا اكزيلاري سامبلنج
ولا سنتينل؟
سنتينل يعني في نقطة.
دكتور شريف
تعمل اكزيلاري كليرنس يا دكتور شريف ولا هتعمل اكزيلاري سامبلنج؟ وفي نقطة بس يا دكتور حمدي بيه، العيانين الكانسر كلهم هم يعني predisposing for DVT، فول هيدريشن للعيان، لو دوز اوف مونوكولار ويت من الهيبرين، كنترول بالاي ان ار، مفيش مشكله خالص. المشكله ان العيان الاوبيز الدايابيتيك اللي هو ان كنترولد هايبرتنشن، هم دول اللي فيهم.
هو الدكتور ماهر جاوب على دي وستراتيفايد ذا بيشنت انتو لو ريسك انترميديت ريسك اند هاي ريسك and he pointed out that those who are high risk or intermediate risk should receive DVT prophylaxis. دكتور شريف.
دكتور سعيد باشا، حضرتك هو بالنسبه للمالتيبل تيومرز سواء مالتي سنتريك او مالتي فوكال، احنا بطلنا نحقن الداي البلو داي بتاعت السنتينال ليمف نود بايوبسي ان ذا تيومر باد او اراوند ذا تيومر. احنا دلوقتي بنحقنها على طول ريترو اريولر، لان اتضح ان السنتينال ليمف نود is the same for all the breast. It is not different from location to location in the breast. So even if the patient has multiple tumors, we still do sentinel lymph node biopsy if the criteria are present, like clinically negative lymph nodes. نعم يا فندم؟ لا لو كلينيكالي لا لو هي
باكزيلا والاكسترا نودال سبريت برضه هتعمل
لا يعني الاكزيلا دي سيبريت انتيتي عن البريست. حضرتك بالنسبه للمالتيبل لامبكتوميز ده في المالتي سنتريك او المالتي فوكال
دي بقى حضرتك يعني التيومر سايز معدي 3 4 سم، يعني لما
لو إيه يا
نيجي
فندم؟
نحطها في التي هتبقى تي 3 هتبقى تي 3 تقريبا، وهتلاقي كل الاكزيلا فيها ليمف نود بوزيتيف. هدخل اخد البوزيتيف بس.
لا لو هي كلينيكالي نيجاتيف اكزيلا بعمل سنتينل، انما لو كلينيكالي بوزيتيف اكزيلا بعمل اكزيلري دايسكشن على طول.
تمام.
وبعدين في حاجه ثانيه، في اختلاف الايام دي على نقطه ما اعرفش حضرتك كان قصدك عليها ولا انا اللي فهمت غلط. ان انا لو عندي مالتي فوكال تيومر ومثلا 2 سم و2 سم و2 سم، هل دي تعامل معامله تيومر 6 سم ولا تعامل according to the size of the largest tumor؟ ما زال في اختلافات. الستاندرد procedure now is to stage the tumor according to the size of the largest focus. انما لما عملوا study على الانستنس of lymph node metastasis according to stage، وجدوا ان مع الحالات دي الليمف نود metastasis بتبقى more in parallel with the total size, not the individual largest size. فبقى في اختلاف دلوقتي في النقطة دي ولسه ما وصلوش لحل، انما it is a site of controversy. Should I take the largest tumor and stage according to this size, or add all the size of all the tumors together and stage the tumor accordingly?
Thank you, Dr. Sharif. Any question further?
دكتور سعد يا عيسى بعد اذن حضرتك.
انا بقى
الدكتور سعد
موجود اهو.
دكتور سعد بيه، انا عايز بقى سعد بيه يقول لي الكرايتيريا بتاعت الباثولوجيست فور ديفرنشيشن بتوين داكتال كارسينوما اند جرانيولوماتوس ماستايتس.
دي عاوز اعرفك انا احنا من كام
سنه
دي مش كده، دي بتعمل قواضي. لان البيت فولز في الدياجنوزس بفاين نيدل فيري هاي، انك انت تشخص حاله جرانيولوماتوس ماستايتس مع ايزف كانسر، مع كانسر يعني كويس. الكرايتيريا اللي انت بتشخصها انك بتلاقي انفلاماتوري سيلز وبارتيكولاري مالتي نيوكليتي جاينت سيلز. المالتي نيوكليتي جاينت سيلز ده اللاند مارك للجرانيولوماتوس ماستايتس، واخد بال سعادتك؟ بالاضافه الى انك بتشوف سيلز ما فيهاش نيوكلير اتيبيا وكده. وفي الغالب بنعمل لها عشان نفرق بين الاثنين بنعمل لها وان ماركر اللي هو بانسايتوكيراتين. البانسايتوكيراتين هايلايت تيومر سيلز فيرسس ذا هيستوسايتس، لان جرانيولوماتوس ماستايتس عباره عن هيستوسيستيك ديزيز ديو تو اوتو اميون ديزيز. يعني كان في مع عمرو، دكتور عمرو عندنا في المعهد عمل شغل كتير على الجرانيولوماتوس ماستايتس عشان يشوف ايام ما كان بيدرس الانفلاماتوري بريست كانسر هو الاي بي سي. فانت عندك ممكن تفرق وان ماركر.
Another question for Professor Saad Isa, if you allow me. There is now a new theory that is being discussed worldwide about the DCIS, and they call this is a misnomer because it doesn't explain why some of them behave aggressively and others are less. And they compare the breast with the prostate, and there is some equal anatomical classifications of the breast compared to the prostate. So the new theory assumes that in situ carcinoma can be divided into acinar type and ductal type in comparing with the prostate. And the acinar type is the more benign form, less aggressive, and it can stay as is for some long time. On contrary, the ductal one in situ is the more aggressive. I would like to have your opinion about that.
Yes. Of course, it is more prominent in the prostate than the breast. And I remind you that the classification in histopathology is only morphology. We are not based on a biologic behavior. What we have done till now is that classify DCIS into 3, and then we make it like down to high and low. Because the treatment is completely different between high grade DCIS versus low grade, which comprise at least 4 or 5 types, subtypes. That's all. Like the point of having in the breast acinar versus it needs, as I mentioned and I show you, electron microscopy or DNA microarray. You don't rely on morphology alone.
Thank you. I think we have one more question from Dr. Akram, and then we close the session.
Dr. Sharif Bey, do you think that the use of intraoperative ultrasound will help to improve the outcome of breast surgery in cases of MIBC?
It's a very important question, and I really think that intraoperative ultrasound will be an essential part of surgery of the breast very, very soon. There is a lot.
Chief, أنا آسف بس I interrupt you. There is a thesis study running out at our department with the use of intraoperative ultrasound in assessment of the margin of breast cancer, not only the minimally. You can continue, but it is running nowadays in our department.
هو the role of ultrasound will definitely gain importance more and more with time in breast surgery, because there is a lot of times where you deal with non-palpable tumors, where you deal with multiple tumors, when you want to assess safety margin after lumpectomy, when you want to assess the sentinel nodes that has been marked before neoadjuvant chemotherapy, when you have to assess the response to neoadjuvant chemotherapy during surgery in tumors that have almost vanished. So the role of intraoperative ultrasound will definitely gain more and more importance. And I think a very important part of the breast surgeon training should be the use of ultrasound.
I'd like to thank Dr. Kram for this question. It opened the door for the use of ultrasound, which is actually happening now. There is a thesis in our department supervised by, I don't know, ما يعني يقدروا لنا المشرفين وفي من radiology department, and I'm sure in the next conferences we'll give you the results of this. It was about the assessment of the margin. I'd like to thank all the audience for staying with us till that long. It was a long session, and the panelists as well, my co-chair persons, everybody has had his effort and stayed for that long, and I would like to wish you a very good day in the conference today and tomorrow. Thank you very much.
ان شاء الله كوفي بريك لواحدة ونص، وان شاء الله نستارت السيشن اللي جايه 1:30 عشان احنا كان عندنا ديلي في البدايه. بس شكرا لحضرتك.
ماشي يا باشا، تسلم ايدك.
مين اول واحد اكتبها؟ ماشي. السيشن الاولانيه. Welcome everybody. It's our pleasure now to start this session. We will begin with Dr. Nadia Mukhtar. She is one of our eminent professors at the NCI. She will give a talk on updates on prognostic and predictive markers of breast cancer in the digital area. Good afternoon, everybody. I'm glad to be here. It's an honor for me to join the Baheya conference every year. And special thanks to Dr. Ghada Abdsalam for her kind invitation. My talk today, my talk today, I have really chosen the subject of updates on prognostic and predictive markers of breast cancer, specifically in the digital era that we're living in today. The fact that digital pathology, deep learning, and artificial intelligence play a major role in pathology today. So artificial intelligence is not the science of tomorrow, but it's the science of today. And because I have only 20 minutes to go through my talk, so I better move on to conflict of interest. And this is the outline of my talk. I'll take you through it. First of all, I talk about the predictive markers. Most importantly, PD-L1, ER, low, and HER2 low. These are new rules in old parameters. The parameters, we know them quite a long time ago, but now a change has been added to their definition and expression. Then I move to some prognostic markers and the difficulty that we face as pathologists in the lab in trying to implement these new rules in these new parameters. Lastly, I will tell you how digital pathology and artificial intelligence can help us solve these contradictive issues. So I'll begin with the predictive markers. PD-L1. PD-L1, we use it by immunohistochemistry. It's a monoclonal antibody, and it's supposedly given in recurrent or late cases with or without combination therapy. Now, in 2021, there was a very famous accelerated given therapeutic protocol, but it was called the clone of
SP142 gained some famous reactions. However, it was withdrawn and it was then replaced by the other clone, which is the clone 22CN3. These are really important messages that I give today because it's important to use the proper monoclone for the proper test. And it is now an approved therapy for immunotherapy protocol. Now, how do we then measure the PD-L1? We have a complicated scoring method in which we count all the cells that are positive for the immune reaction of PD-L1, namely the lymphocytes, the macrophages, as well as the tumor cells. It's not really important to differentiate at that stage, but we count them collectively, and that is why it is called combined positive score. The number of positive cells will then be multiplied by 100 and divided by the total number of viable tumor cells. And here viability is very important. We do not include inflammatory reaction, and that's again an important issue that we have to consider. Now, then the result will be subdivided into positive or negative. However, for clinical implications, it's positive, that is in therapy, combined positive score is for that. It's very, very important. Now, the result that we found, about 20% of our cases are positive for PD-L1 reactivity. And this is a photo microgram of a case of positivity with a combined positive score of 17. So it's more than 10, so it's positive. However, and I will say a lot of however's in my speech now, in the same tumor, we could find an area that is totally negative. And why is that? Why part be positive and the other because of the very famous phenomenon in cancer tumor. What is supposed to be done is to screen the whole slide, just hold the whole slide. In younger females, that is females younger than 40 years. And this is a case that was positive in a female. She's 36 years, she's supposedly young, and this is a highly positive case for PD-L1. So the difficulty that we're showing is that tumor heterogeneity really is a problem to us. We have to score as much cells as possible, more than 1,000 cells or so, and that is really over the capacity. So this is the first marker that I talked about. Now I move to another yet new rule in an old parameter, namely what is called ER low. Now the ER positive and the ER negative are well known to us. However, a new terminology now emerged saying that a tumor with less number of ER positive cells is called ER low. And here, when the cells are only from 1 to 10% positivity of ER expression. The intensity here is not important. However, it is usually of low intensity. So what about the overall benefit of endocrine therapy to these patients that have low level of ER positivity? Again, we go back to the problem of tumor heterogeneity. They are a heterogeneous group, both in behavior and biology, and they often have the gene expression profile like similar to ER negative cancer. So not related more to the ER positive, but related to the ER negative. And here, a multitude of studies showing that the ER low is now consisting about 2 to 3 or maybe maximally 5% in many of the series, contradistinction to the ER positive, 85%, and the ER negative, 15%. So although there are a small amount of patients or cases, we do come across them now. We consider to really count them particularly important. What about the biology of this type of tumor? As we see, the ER low, they are different biologically from the ER high. Namely, that the ER low is more towards the basal phenotype with less luminal A and B versus the ER positive or high, which is oppositely high in luminal A and B phenotype and very low on basal characters. So we really think that these are two different diseases, and again, different from ER negative altogether. We look at these photos that might perplex us in the lab. The negative is clear cut and the positive is clear cut, but we have an intermediary where we can, ask ourselves, is this positive? Is this 1%? Is this more than 10%? I could say it's low. Dr. Ghada could call it high, whatever. This is due to the subjectivity of the human eye. We are not machine. Again, another problem that can face us is the prompt tissue fixation. As the tissue is outside the body and not properly fixed, it loses the antigenicity and the immune histochemical reaction. The longer the time, the more it will be destroyed or devaluated. So much so that ER weakly positive would then become totally negative if not properly fixed, or a strongly positive can become weakly positive also due to the inadequate prompt fixation. So here is a word to you that we should have properly fixed tissue and adequate material for the reasons we just showed. Another point of interest is the DCIS. The DCIS is separate from the invasive component. We can have cases positive for ER in the DCIS component and not in the invasive component. Moreover, the DCIS can also be heterogeneous in a way that some of them may be ER strongly positive while others are negative. And when we have a DCIS component in an invasive component, we do not really mention it much because it has no impact. However, if the tumor is solidly DCIS, then we have to look for the positive areas and the negative areas and consider which one stronger. Here, it's always said that it is called multiclonal and not heterogeneous. It's multiclonal. It's as if the patient is having two different diseases, but the prognosis will be governed by the more aggressive one, that is the ER negative. So multiclonality of the estrogen receptor in ductal carcinoma in situ is now very well known, and it is rather prognostic rather than predictive. Now, HER2 low. HER2 low breast cancer is again a newly introduced subset of HER2 negative breast cancer. Whether there are two options, either it could have a score +1 by immunohistochemistry, or a score +2 with negative CISH or FISH. Now, recent clinical trials have demonstrated there is a significant clinical benefit of the anti-HER2 therapy with drug conjugates ADC in treating this group of patients. The trastuzumab DXd. Here again is a borderline reaction. Again, I could say this is +1. Another pathologist would say it is +2 in some areas. And again, going back to the subjectivity of the human eye, and we have to resort to fish. We wish that we could have strict subdividing categories, but we don't. We have a shady scale of increasing percentages so that we do not really have a distinct cutoff values in the area where the tumor is from 1% up to 10%. And we have to segregate that from the negative component on one side and the positive tumors on the other. Here, for HER2, we had a 2-tier scoring system, but now we have 3-tier scoring system, and we have to consider this intermediate area of HER2 low. Again, this is one case that could cause problems between pathologists. We are limited by our subjectivity. I could say this is +1, others could say this is non-specific and negative, and many others could say maybe it's +2. So what about the biology of HER2 low? Now, HER2 low, most of them will be related towards the luminal A and the B, and not towards the HER2 plus. So, and again, they are enriched by hormones, but they have a low proliferation index. And therefore, HER2 low is more related to the HER2 negative rather than the HER2 positive. So why are we there? What are these patients then having advantages of the therapy? Simply because they found that there is enough number of molecules on the cell receptor, maybe up to 100,000 molecules of HER2 on these cells. Of course, the positive cells would have millions, but the low HER2 cells would have 100,000 molecules, giving it the threshold of unique bystander killing effect, and that is why they can benefit from targeted therapy as well. Now we move to prognostic markers. Ki-67 is a great help to all pathologists, and we always use this favorable clone, which is the MEP1. Now, the cutoff for the high risk recurrence is 20%, and thank God that it's being stable for that number for some time now. 20% is the cutoff value, which then can say whether this patient is at high risk for recurrence and thus have adequate therapy or not. Here are cases that all are having 20% or more reactive immunohistochemical reaction for Ki-67. However, this is maybe one tumor that could have those 3 parameters presented. Some areas would show less than 20%, others may show just about 20%, and some other areas would show very high density positive proliferating cells. We use the process of eyeballing, that is, we just see the impression and record it, or we can use an image analyzer, which is more accurate. We have to count up to 1,000 cells if we want to be sure whether we want to count the hotspots or count the heterogeneous areas, or just do a whole scale for the whole section. And here is where we come and need the help of digital pathology, deep learning, and artificial intelligence. It is a scanner that will convert the photo to a digital image, and hence every spot, micro spot will have its own integral signal to provide. We teach the instrument And then the instrument will do data manipulation, proper equations, and give a precise decision, especially in those gray zone areas that I just mentioned. And this is an example of a slide scanner that will take a lot of slides at a time and also scan the whole slide and count more than 1,000 or 5,000 in case here when it becomes an objective means of deciding on the reaction. We moved a lot to the milestones of computerized pathology, and now in the year 2020 and beyond, we have come to the digital pathology whole slide scanning solution, and it's finally there. So the digital pathology will help us a lot in the gray zones. It will be more objective than our subjectivity. It will really store a lot of digital data sets. Up to millions of cells will be counted, validated by the lab, and putting standardization for each lab. We can use this for consultation cases. We can send the slide to be scanned anywhere in the world, and we can use it in education. And definitely, and most importantly, when a pathologist is sitting in the MDT meeting, he will have precise, very delicate answer to each and individual case. This case is ER low, this case is HER2 low, or otherwise. The quantitative image analyzer is now well established and can read ER, PR2, and AI very quickly and very precisely. Now, artificial intelligence, we can teach the machines to detect mitosis and thus refine the grades. The grade 2 tumor is now being more refined into a low grade 2 and a high grade 2. Lymph node, we could also teach the machine to recognize micrometastasis or even individual solitary metastatic cells. The TILs, which are very important in establishing some prognostic and predictive markers. It is very difficult for us to count the TILs, but we can teach the machine to do it for us, and can predict the molecular expression as well from very simple H&E section. And this is being taught to some machines to do it. And in the end, it will reduce pathology workload, not that we do not want to work, but because machines are doing it for us, to improve the diagnostic and the scoring accuracy, reduce human error, and overrule the tumor heterogeneity and hotspots and so forth. The literature is full of references about the present impact of artificial intelligence. And there's nothing really intelligent about artificial intelligence. It's the human intelligence that made us realize how we can use some machines to do a better job than us. Thank you.
Thanks, Dr. Nadia. As usual, interesting and comprehensive. Any questions? It will be postponed at the end of the session.
I would like to present Professor Dr. Mona Mamdouh. For the talk, she will talk about update on HER2 new classification. Thank you.
Update in HER2 new classification. Estrogen receptor, progesterone receptor, and HER2 are biomarkers which needed for some breast cancer to grow and divide. As part of breast cancer diagnosis, these biomarkers are tested on breast cancer tissue, which act as a predictor into molecular subtypes. These molecular subtypes tells us what is feeding the breast cancer and determines the types of treatment that cancer is likely to respond, such as hormone blocking medications in case of hormone receptor positivity, monoclonal targeted therapy in case of HER2 positive, and or chemotherapy. Gene, which is located on chromosome 70. HER2 signaling promotes cell proliferation via the RAS-MAP pathway. HER2 gene amplification can result in passive overexpression of HER2 cell surface receptors. This is a normal cell shown to This is a normal cell show two copy number of HER2 gene with few cell surface receptors. But this is a malignant cell show overexpression of HER2 cell surface receptor due to increased gene copy number. Too many HER2 receptors send more signals, causing the cell to grow too quickly. Breast cancer classified as either positive, HER2 positive or HER2 negative based on protein expression and or gene amplification. HER2 positive is present in 20% of invasive breast cancer. HER2 acts as a predictive and prognostic marker. As HER2 positive breast cancers predict response to HER2 targeted therapy, and they are aggressive tumors with high risk of metastasis and decreased survival compared to HER2 negative breast cancer in case of absence of therapy. ASCO-CAP HER2 testing guideline in breast cancer initially published in 2007, then updated in 2013 and 2018. These guidelines were developed to standardize accurate detection of HER2 gene amplification or protein overexpression in breast cancer for prediction of benefit from HER2 targeted therapy. Recommended methodologies to detect the HER2 are immunohistochemistry, which detect protein expression, or in situ hybridization, which detect gene expression. Guidelines of HER2 protein expression detection by immunohistochemistry is the first test that's done for HER2 assessment. Results are evaluated based on the percentage of positive cells and the degree of intensity of membranous staining. The immunohistochemistry score can be from 0 to 3. HER2 considered negative in case of immunohistochemistry score of 0 or 1. 0 when there is no staining or there is incomplete membrane staining in less than or equal 10% of tumor cells. While immunohistochemistry 1, if there is also incomplete staining of the cell membrane, but in more than 10% of tumor cells. HER2 considered positive when immunohistochemistry is 3. This when there is circumferential membrane staining that is complete and intense in more than 10% of tumor cells. While if there is complete staining, membrane staining observed also in more than 10% of tumor cells, but is weak to moderate, it's considered as equivocal and is scored as immunohistochemistry 2. In this case, reflex in situ hybridization should be done to detect gene amplification. There are other unusual staining patterns of HER2 which are considered as immunohistochemistry too. For example, intense but incomplete circumferential membrane staining, which occurs in some specific subtypes of breast cancer as micropapillary breast cancer, and intense complete circumferential membrane staining, but within less than 10% of tumor cells. This is score 0, score 1, score 2, and score 3 immunohistochemistry. The ASCO-CAP guidelines of HER2 gene amplification detected by in situ hybridization, which may be fluorescence in situ hybridization or bright field in situ immunohistochemistry is equivocal. The winning nuclei should be enumerated. The final results for HER2 status are reported based on the ratio between the chromosome and the gene, and formed by dividing the sum of HER2 gene signals by the sum of chromosome 17 signals for all 20 nuclei, and also based on the average of the HER2 gene signals, and formed by dividing the sum of HER2 gene signals for all 20 nuclei by 20. If the ratio between the gene and the chromosome more than or equal to, and the average of HER2 copy number per cell more than or equal 4, it's HER2 positive. But if the ratio less than 2 and the average less than 4, it's HER2 negative. While if the ratio between the chromosome and between the gene and the chromosome more than 2 but less than 4 or less than 2 and the average more than 4, additional work up is needed. In malignant cells, the image on the left shows non-amplified HER2 gene, but on the right show amplified HER2 gene in the form of clusters. So HER2 positive is reported when immunohistochemistry is scored 3 or scored 2 with HER2 gene amplification by in situ hybridization. HER2 targeted therapy in HER2 positive breast cancer expanded from anti-HER2 monoclonal antibodies to tyrosine kinase inhibitors to anti-HER2 antibody drug conjugates. In summary, HER2 positive breast cancer, which is treated with HER2 targeted therapies, showed dramatic improvement in the clinical outcomes, while HER2 negative breast cancer was not eligible for HER2 targeted therapy, which categories either limited treatment minus immunotherapy. The other possibility must have overall relatively favorable prognosis, but most advanced metastatic cases remain uncurable, and up to 40% of advanced metastatic therapy resistance and options are limited for later line of therapy. Therapeutic options in treating high risk or advanced HER2 negative breast cancer lead to HER2 low breast cancer. HER2 low breast cancer newly defines subset of HER2 negative breast cancer that lack protein overexpression or gene amplification. Still not well characterized clinically and pathologically. Recent clinical trials have identified HER2 low breast cancer as those with HER2 scores of with stabilization rate. These trials HER2 and pre-19 achieved a good objective response rate of HER2 immunohistochemistry scores of 1 or 2 with insight to hybridization negative 2, which responds to HER2